Good day to the attendees, as well as the virtual attendees. A warm welcome to the One Health Antimicrobial Stewardship Training Symposium, hosted by the Department of Pharmacology, which is part of the School of Medicine in the Faculty of Health Sciences at the University of Pretoria. I am Vanessa Steenkamp, the Deputy Dean of Teaching and Learning in the Faculty of Health Sciences. I immediately accepted this invitation extended by our host, Professor Natalie Shellack, and am honored to do the welcome address and set the symposium in motion. The reasons are threefold. Firstly, this is a training symposium and is the core of teaching and learning. Secondly, as some of you may know, the Department of Pharmacology is my research home. And thirdly, the topic of antimicrobial and stewardship is an extremely important topic in health medicine, and hence the exciting program that has brought together colleagues and a keen interest in the topic from different schools, departments, faculties, and institutions. I would like to take the opportunity to introduce our guests to the University of Pretoria. The University of Pretoria is a multi-faculty, research-intensive university and regularly produces the highest per capita percentage of the total South African research output. The university's 9 faculties and business school offer a diverse range of degrees, diplomas, and certificates, as well as more than 1,000 postgraduate programs. The institution has a rich, colorful history, and with its unique mix of academic tradition and progressive vision, it can look forward to the bright future. Its vision is to be Africa's leading research-intensive university, recognized internationally for its quality, relevance, and impact. Relying on more than a century of expertise and well-established faculties, UP develops human capital and generates the knowledge and skills required to meet the challenges of the world at large within the context of a developing nation. The Faculty of Health Sciences has a long and proud tradition of excellence in the education of healthcare professionals. Cutting-edge research ensures that teaching and learning is in line with the 4th Industrial Revolution in order to train a new generation of healthcare professionals. Students who join the faculty receive ample and varied hands-on clinical experience in various hospitals, clinics, and community settings, and are thus equipped to become productive members of society with long-term positive impacts on communities. At present, in excess of 31,000 of the faculty's alumni are working in more than 50 countries. Currently, 5,000 undergraduate and 1,500 postgraduate students are enrolled in the faculty, which offers specialist medical and dental training and fellowships in more than 43 disciplines. Students are trained by 600 academic staff members located in 4 schools, namely the School of Dentistry, Health Sciences, Medicine and Health Systems, and Public Health. The Faculty of Health Sciences includes 14 institutes, centers, and entities, which are the hallmark of research of the faculty. The research focus is on the health and healthcare challenges facing South Africa and Africa, and research ranges from laboratory-based cutting-edge science to community-based initiatives to finding solutions to healthcare burdens. This brings us to the topic of today, antimicrobial stewardship. The use of the term antimicrobial stewardship has grown exponentially in recent years, typically referring to programs and interventions that aim to optimize antimicrobial use. Although antimicrobial stewardship organized within human healthcare, it is increasingly applied in broader contexts, including animal health and One Health. One Health was included in the title of this symposium by no mistake. One Health is a collaborative, multisectoral, and transdisciplinary approach, working at the local, regional, national, and global levels, with the goal of achieving optimal health outcomes, recognizing the interconnection between people, animals, plants, and their shared environment. And this is the essence of antimicrobial stewardship. In the early days of antibiotics, booming drug development meant that even when resistance developed, a new drug was always available to treat the increasing resistant bacteria. 14 new classes of antibiotics were introduced between 1935 and 2003. However, rapid antimicrobial development came with a cost: antimicrobial resistance. In the hospital, resistance to antibiotics and antifungals poses the greatest threat. Now, nearly 2 decades ago, in America's intensive care units, it was reported to the Centers of Disease Control and Prevention that nearly 60% of Staphylococcus aureus isolates were resistant to methicillin. Perhaps even more difficult to manage has been the increase in gram-negative resistance. Programs such as the International SMART, that's a study for monitoring antimicrobial resistance trend, and the Century Antimicrobial Surveillance Program has shown substantial increases in the rate of Klebsiella resistance to third-generation cephalosporins and extended spectrum beta lactamase producing Klebsiella pneumonia, and E. coli and Pseudomonas resistant to fluoroquinolines. During the past 30 years, antibiotic development has showed considerable changes, and our options for treating increasingly resistant infections are becoming more and more limited. Thousands of people die of infections caused by antibiotic resistance and such organisms every year. Every day, patients die of bacterial infections for which no active agents are available. Yet, since 1998, only 10 new antibiotics have been approved, only 2 of which, linezolid and daptomycin, actually have new targets of action. The reasons for this are simple. Drug development is risky and expensive, and drugs to treat infections are not as profitable as those that treat chronic disease. Antibiotics currently in development are in existing classes and are broad spectrum in nature, which means they are likely to further promote the development of resistance if approved and used. The goal of antimicrobial stewardship is threefold. The first goal is to work with healthcare practitioners to help each patient receive the most appropriate antimicrobial with the correct dose and duration, referred to as the 4 Ds of optimal antimicrobial therapy: right drug, right dose, de-escalation to pathogen-directed therapy, and right duration of therapy. An added benefit of programs that aim to optimize antibiotic use is that they generally experience cost savings because doses of antibiotic are used and less expensive antibiotics are chosen. The second goal is to prevent antimicrobial overuse, misuse, and abuse. In both the hospital and the outpatient setting, Physicians use antibiotics when they are not necessary. It is common knowledge that antibiotics are given to patients with viral infections, non-infectious processes, bacterial infections that do not require antibiotics, and bacterial colonization. Antibiotics are also frequently misused, such as in the very common scenario of the use of broad-spectrum antibiotics that cover multi-drug resistant organisms in a patient where infections was required in the community, or the failure to adjust antibiotics according to culture data, thus maintaining the patient on a regimen to which the organism is not susceptible. The third goal is to minimize the development of resistance, both at the individual patient level, at the community level. Use changes are required to change susceptibility patterns. Now, viewing the program, this training symposium is setting out to prove to you with what the why, the who, the how, the when, and where of antimicrobial stewardship. This will cover many of the aspects I have alluded to, albeit very briefly. I wish you a fruitful symposium. Thank you very much. Before I hand over to the chair, I would just like to make one announcement, and that is for our virtual attendees. At the end of each of the sessions, there will be a code for the CPD points. So if you just note that you can claim your CPD points. Thank you.
Thank you very much, Prof. Steenkamp, for the welcome. And thank you, Prof. Schellek, for putting all of us together. Our first session will focus on where we currently are with antimicrobial stewardship. We've got four of the best experts that we could gather in front of me, and they'll entertain you in the next session. The questions we'll discuss at the end of the session, so we won't allow questions after each speaker. So our first speaker is Professor Vinny Naidu. He's the Dean of the Faculty of Veterinary Sciences. Are you the first speaker? I'm so, let's get that, sorry. Our first speaker is Prof. Schellek, sorry for that. She's the head of the Department of Pharmacology, and she serves on many national committees regarding aspects of antimicrobial stewardship. She has put this wonderful program for us together, and she's going to tell us what is the overview on antimicrobial stewardship regarding human health. Thank you, Natalie.
Thanks. Can everyone hear me? Okay, thanks, Prof. Avenant, for the kind introduction. Thank you, Prof. Steenkamp, also for really setting the scene. And thank you, everyone, for joining us today and being equally as passionate about, conserving antibiotics as we are. And I'm really looking forward to this UP initiative and all of the faculties and everyone that can collaborate. So today really is an overview of antibiotics in human health and the research that we've conducted so far. And I wish our colleague, Professor Veronica Uckerman, could also join us, but she's having a lovely time in Namibia. So she was part of I just want to mention, she was part of our initiative to drive this. So I wanted to ask all of you here today, can we foretell the future? So Prof. Steenkamp has alluded to, really where we are going, and everyone is always painting this very grim picture. I mean, many of you have already become so used to it that it doesn't even shock you if I showed you this. Are we losing the fight against superbugs? And even the word fight, as academics, we get stuck on words, but even the word fight has now become, we don't want to use it anymore. But many of the market leaders and people in the pharma industry would ask, where are we going to go? Where are we going in the future? And there are many different players that plays a role. We've mentioned use, we've mentioned environmental health, we've mentioned catastrophic events, and then we can also think about, looking at a black swan event. So when we talk about the black swan event, then a black swan is really the hazard that we currently have with the changes in evolution of resistance. So notably, we have predictable changes in microbial resistance, but then there are also a few of those mutations which escape and then now is unpreceded. And then our colleague from microbiology is going to talk about a little bit more about that. But that there are really new resistance genes, and what they do is they just recruit environmentally many of the other promiscuous, if you want to put it like that, mobile elements, creating a swan event. So such events can really change the resistance landscape that we are currently seeing rapidly and unexpectedly, and Prof. Steenkamp has alluded to, as with the rise of Escherichia coli, ST131, and even CTXM ESBLs in the emergence of the impossible VRE that we've seen. So given all of these unpredictabilities, we simply cannot say for certainty which of the 4 current approaches that we have in stewardship is really going to offer us the most noteworthy, prize-worthy success. So with this training program, we are hoping to bring together all of these minds so that we can really show what the future can hold, and that we can look at developing both enablers and really tackling some of the barriers that we have that we will be discussing today. So this is hot off the press that I want to share with you. This picture that you have here is that CRE prevalence in the public sector, now recently presented at ECMID by Prof. Olga Perovic and colleagues, has shown that colistin drug resistance was reported in 18.6% of all of the isolates across the public sector hospitals. And that really, I hope, is showing us that we've got a problem. And then we know that we have the overview of antimicrobials, and we know that our drug lines are really running dry at this moment, as you can see, and there are natural and synthetic ones. And when we talk about chemotherapeutic agents, we like using that term, but chemotherapeutic agents are just pharmacological agents, that rapidly change. And you can see, even when you look at this, you can see in the 1900s, we've actually already started looking at some of the synthetic antibiotics that are used clinically. But where does bacterial resistance come from? Is it something new? Is it something that we just started? And the actual fact is no. There were archaeologists that went to Tucson in Alaska, and they were actually looking for equitus, equus, lagopiths. They were looking for ovis. And what they found is when they started drilling down in Dawson, in Alaska, is they found bacteria that were already 4 billion years in existence. So these are not the black swans. These are the ones that we know, that we can work with. It's those ones that escape and become promiscuous that we are really worried about. But what was surprising in this paper that was published in Nature in 2011 is that in these 30,000-year-old permafrost samples, they detected the following metagenomic genes, and in the study, they found beta-lactamase, they found ribosomal proteins, which confers resistance to tetracyclines, they found D-allo-dipeptide hydrolase VANC-X, which is the component for vancomycin resistance. They found an aminoglycoside antibiotic modifying acetyltransferase ribosome methyltransferase, and they found which blocks the binding of macrolides, lincosamide, and get this, type B streptogramin antibiotics in a 30,000-year-old permafrost sample. So what does that tell us? It tells us that we know that antibiotic resistance is a natural phenomenon that predates the modern selective pressure of agriculture and clinical antibiotic use. But what is really important is how we are going to manage these new players, the black swans that we have, if you want to look at it like that. So I just want to spend a minute on the human microbiome because I think it's an important part of stewardship. Is when you look at this, the human microbiota consists of 10 to 100 trillion symbiotic microbial cells that we have that are harbored by each person sitting here. And the human microbiome consists of genes that these cells harbor. Microbiome projects worldwide have been launched with the goal of understanding the role that these symbionts play and their impact on human health. And just as we've always asked in philosophy, which is not the class that we are in today, is what it is to be human, we are also looking at what is the human microbiome. And I think when we look at, there's some confusion in terminology, for example, microbiota that people would confer to, which is the microbial taxa associated with humans, and microbiome, the catalogue of these microbes and their genes. But I think why this is important is that there's the concept of colonization resistance. So I don't know if any one of you know where this is. So this is Kowloon City, and it was really part of Hong Kong, and it was demolished in 1991. And why it was demolished is because there was 1.15 million people that lived there per square meter. So it was overpopulated. But this is our gut, and for the ladies in the audience, that 2.2 kilograms that you have extra is not you, it's not the food. It really is just 2.2 kilograms of bacteria in your colon, 100 trillion. And each one of these are really important in colonization resistance. So when we look at the effects of antibiotics on the microbiome in the gut, what you can see on the slide there is really that is where the gut actually ends, or the colon. And that is the effect of inflammation from a single course of antibiotics. And that is super important to note because you lose your own microbiome and your own microorganisms when you start using antibiotics. So is it time for a paradigm shift in the way in which we manage serious infections? I think the best, or one of the biggest challenges that we currently have in our landscape, and that's certainly something that keeps me up at night, is to encourage stewardship by looking at how are we going to use the antibiotics that we currently have versus the new kids on the block. And we don't really have kids on the block. We've got antibiotics with new beta-lactamase inhibitors, for example. So we've got the two new novel molecules, ceftazidime and avibactam, and ceftolozane tazobactam, are the first of the new generation bleaks that are registered in South Africa, and we were really hoping to preempt their launch with some guidelines, but we missed the boat, and I want you to know that their consumption has gone up by 368% in 2 years. So their potential uncontrolled use, because we are looking at a one-size-fits-all treatment for the resistant gram-negative bacteria that we are seeing, is really catastrophic every time that we launch a new molecule. So we must really start thinking about a paradigm shift. So we've got in our current landscape infections due to multi-drug resistant gram-negative bacteria that is rapidly evolving. Carbapenem-resistant Klebsiella pneumonia is the most commonly encountered carbapenemase producer of the Enterobacteriales group and is really a major cause of high mortality and hospital-related infections. And that is one of the biggest challenges that we face in South Africa today. So we need enhanced surveillance, and that's why we have all of our multi-resistant panelists here today, but they are certainly not resistant. But our multidisciplinary interaction here today, because we need surveillance. And with surveillance, really, we saw in the Western Cape a significant increase in the proportion of cases reported with Enterobacteriales carbapenemase resistant. And then another available option for the treatment of hospital-acquired infections due to carbapenem-resistant Pseudomonas aeruginosa are also scarce. And I think that is why we are seeing an 18.6% increase in colistin resistance. So there is going to be a lot of attention paid to stewardship. And if we look around what stewardship really means, and Prof. Steenkamp has alluded to it, is there's many different aspects that we have to look at, and we need all hands on deck. We have to start thinking about infection prevention and control, and that's often the orphan child. No one wants to do it because it doesn't sound sexy. I mean, for us to space out is not a sexy thing to do. So we often don't get people that are very involved in there, but we need them. The moment that we have a patient coming in that's resistant, or that could have a very a highly transmissible disease, they should be quarantined. We have to educate staff, we have to prescribe antibiotics when they are really needed, etc., etc. And I'm going to talk about some of the few aspects around that. So if you look at this is the new drugs that are approved or in clinical development with activity against multi-drug resistant gram-negatives. And I'm not going to really talk about this a lot, but what I want you to look at is when you look at all of the resistant genes that we have there, and you look at all of the new molecules that are either in post-market phase 1, preclinical post-market phase, or phase 3, can you see any one of those except the last two that we don't even know that are in phase 1 or preclinical that could cover all of these resistant genes that we have? And those gaps are often the patients that we admit in the hospital. So let's look at supporting surveillance of antimicrobial resistance and hospital-acquired infections. So one of the most difficult things is to get a stewardship program in a hospital or in a faculty like ours, because there are some terms that also really aren't very sexy. Management also wants to know how much is it going to cost. People want to know what are they going to measure. And for that, we need structural processes, we need process measures, and we need outcome measures, and we need hard endpoints. But how do we drive action with data? Because you could give many people many reports, and we were just discussing that. In all of these committees that we sit, we would get all of these reports. This is the use of antibiotics, or this is the use of resistance. But what are we going to do about that? So why do we measure? We measure to prove our worth. Why are we doing stewardship? Why do we need someone? Unfortunately, we've got all of those fancy things that I've put in front there. Those are politically correct things to say, for example, to achieve what we wanted. Those are the things that we put in our report. But what we really know to be true, to get funding for our activities, is really to show what are we worth and to really help prescribers and clinicians and patients. What do we need to measure? Many hospitals struggle with this question. What do we need to measure? We need to measure meaningful data, but getting meaningful data in a hospital that is just really also trying to keep patients alive is difficult, so we need to put those measures in place. And one of those measures, or some of these measures that we need access to, is unstructured or even structured data, because you can also do a lot with unstructured data if you structure the parameters around it correctly. We need, one of the challenges is a lack of interoperability, a lack of definitions. Many people don't understand what the word means. And then beware of administrative data, because administrative data was not there for you to guide your stewardship efforts. It's there for administration. So that should be seen in context. And always remember, all of these electronic health records, great, wonderful, fantastic, but if you put in rubbish, you're going to get out rubbish. So these are the types of measures that we are proposing. So in other words, for any hospital to start a successful stewardship process, we have to look at the structure. In other words, what do we need to put in place? What are we doing? That's the process. And what do we want to achieve? For quantity of antibiotic consumption, this is then also something that the WHO is guiding us with. Defined daily dosages is the golden guideline where we want to go to. Days of therapy is not necessarily affected by dose, and sometimes we can't use dose, because if a patient's volume of distribution is very big, and you've got a hydrophilic molecule, you need to up dose. Then your DDDs are not going to work, and we have to look at adjusted for the population. One of the biggest questions that we get asked is, we are focusing on South Africa, but what is happening in Africa? So for that reason, we came together. We've got a group of colleagues that are working across Africa, and we said during EuroDirg that the African colleagues came together, and we said we want to start looking at usage patterns. This was already in 2015. And then the MIRIA group, which is a group that all of you can belong to, it's a medicine utilization research in Africa, said we must start working together, a multidisciplinary. It can't just be a pharmacist or just a doctor or just a microbiologist. We need everyone or a nurse to talk together. And then what we did is we said, okay, well, let's look at some of the high income countries and lower middle income countries, and then we can collaborate. What works for the higher middle income countries won't necessarily work for us, so it's not a plug and play. So then we said we need a lot of studies. We need to work together, not only as South Africa, but as Africa. But when we focus on South Africa, the overwhelming majority of South Africans rely on the public health sector, and then the public sector still remains or requires the greatest amount of resources. But we know that only 17 in every 100 South Africans have got medical insurance. And that means that 86% of our patient population is in the provincial government, which is tasked to manage the nation's public healthcare system, comprising of 422 hospitals and 3,841 clinics and health sector. As we are moving to the national health insurance, all of this needs to be funded. So South Africa luckily came together, and we have a South Africa Antimicrobial Resistance National Strategy Framework with outcomes that are set to be met in 2024. And this was really supported by the Minister of Health and driven by the Minister of Health. And as you can see, this is from that report. You can see even our program is structured around this, surveillance, stewardship, and infection prevention. And all of this is where the university is really important, and where I want to ask all of the academics, all of the students, all of the postgrads that are listening today is, are we spending enough time in educating our students in whichever discipline they are on the importance of this really big problem that we are facing? So when we started these research efforts, we wanted all of our colleagues, you'll see some of the colleagues from the NHLS, for example, to look at what is the current situational analysis of antimicrobial in South Africa. And we couldn't access data from the public healthcare, the government hospitals, because it's not an electronic health record system. So we used tender data, and then we put it into marketing terms because we have to sell it to people. We have to tell them, what is happening in a marketing term that they can understand. And we saw that in the private sector, antimicrobial use from 2014 to 2016 decreased with a compound annual growth rate by 2%. But when we looked at the public sector, it was driven, these were the drugs that were part of that, linezolid as mentioned, and tigecycline was prescribed often. And then when we looked at the public sector, what you can see there is that the broad-spectrum penicillins were used the most, followed by trimethoprim combinations. And if you put this in a global context, you would think it's for a UTI, but we know in our case, it's for Pneumocystis jirovecii that we use it. And look at that, all of the other antibacterials made up the largest part of the compound annual growth rate. And that was because linezolid was not filtered out, and it was used for multi-drug resistant TB. But utilization went up by 11% in the public sector. Antiretrovirals, the same thing. It grew in the private sector by 470% in the public sector. TB, we saw a lot of increases in prevention, isoniazid and rifampicin. And why this is important is because it shows us that our prescribers are focusing on prevention as well. So then when we saw colistin resistance, we published some papers around what can we do, some dosing guidelines in 2016. But we recognized our colleagues, from the veterinary health environment, and we said we needed to work together because we found resistant genes in milk. So then the South African Veterinary Council some of our colleagues are here, were very visionary, and they sent this out to the veterinarians. They were very strict. They said colistin should not be used in food-producing animals at all, unless the veterinarian can justify its use at the hand of a sensitivity test, which is really bold, and then published a paper on the One Health stewardship of colistin as an antibiotic for last resort, putting this in writing. So then we saw, when you look at the WHO e-health profile of South Africa, you can access this, it's really interesting. Look at that. South Africa has got 165% or users, so it means on average every person in South Africa has 1.6 phones. So even though we don't have access to Wi-Fi, we've got more than one phone. So then we thought, fantastic, let's use that in stewardship. And we looked at e-health. E-health is an elephant with lots of different aspects, but for the sake of time, I'm not going to go into that. But we used mHealth. And then we did the same study that we used paper-based and tender data again across South Africa with an app that was developed and is now freely available to all public hospitals. We train people in every public hospital to use the app for a point prevalence. We first piloted it in a hospital because we also recognized that the hospitals were built as part of the previous government and weren't really built for Wi-Fi accessibility. So we wanted to understand if the app is going to work. Many hospitals don't even have Wi-Fi. But we tested it and it worked, and that's the login screen. You can get it on an app store. We looked at how easy it is to use. Everyone that used it said it was easy to use. It took you 6 minutes to put in consumption into an app where it takes you 32 minutes if you had to do a paper-based system. And we saw more or less, as you can see, when we did this with the app, that utilization was the same. Beta-lactam antibacterials were used most often in the public sector. Okay, then, just for the sake of time, we need to work together into the interdisciplinary health. We need air support. There's your air support. You can do it. So we had our whole government behind us. You can see it was signed by many different stakeholders, the AMR plan, and even from top down, it says we need to work together like we are doing today. This is the group's website if you want to join it, if you want to become part of our African colleagues. So where do we go? We need to start educating staff. When we did a survey 2 years ago around in the clinics, in all of the clinics, just to ask them, do they know about this framework? And what we found across these clinics, across the 9 provinces, is that most of the nurses said they knew about the framework, but they can never do a culture. If they do a culture for a patient, they never get the results back. So they really can't follow some of the guidelines, which is important. We looked at fourth-year pharmacy students' knowledge and perceptions across education, the schools that are offering it. And what we found is that we don't offer the same education across the universities. And then a prenuptial agreement may need to be entered into between the hospital management team and clinicians to say, we are signing this prenuptial agreement. If you prescribe therapy that you shouldn't be prescribing, it's going to affect your performance management. So then, just ending it off is we need the team. We need everyone on board. We need to work together, and we need esprit de corps, which is a French term that we use to say call to arms, that they used in the Second World War to say that nurses need to work together as well. They really do well in the emergency department to manage stewardship. And then lastly, we need the taxi drivers. This is the study that we've done in the taxi community. And we asked them if they have a word for stewardship. All the blue blocks that you can see there, no words. There's no words that they understand stewardship. So in South Africa, with the 11 different languages, most of the population we can't translate it to. And then we sent in mystery shoppers, this is one of my last slides, to find out how easily we can access antibiotics, and we could get it rather easily, especially for UTIs where they got STD treatment. So I think when we look at all of these things, and just to end off, that's pharmacokinetics, we need to move towards the individual patient. And we can look at the drug and drug combination, the microbe, the host. And this is a new term for stewardship, is pharmacoecological factors, which talks about language, the environment, and in which family are you sending that patient home. So I think at the end of the day, regardless of generalist versus specialist practice model, we need to work together, and we need to work together in a multidisciplinary team approach. Thank you for your time. Thank you, Chief.
Thank you, Natalie. Now you can see we've really got the country experts on antimicrobial stewardship here. So the next one is, in his own right, the expert in the country on the prudent use of antibiotics in veterinary health. It's Prof. Vinny Naidu. He's the Dean of the Faculty of Veterinary Sciences, and his research expertise is on different aspects of pharmacology. And like I said, he's involved in many of these activities regarding the control of antibiotic use. Welcome.
Good morning, everybody. So, considering we are at the health faculty, I thought today's presentation, I'll talk about more the veterinary industry, more generalized, so people understand the context of AMR and how it impacts on us, and not look specifically at the resistance. So, just to set the scene, if I can go forward. There we go. Yeah. So, how does the veterinary industry impact on me? Now, most people will say it's animals, it has nothing to do with human health, and the two shall never meet. But is it really that case? Now, if you consider that at any one time, there's more animals in the country than people, you have to look at it in a different light. Now, how do people interact with animals? Because that is the important thing. Veterinary health takes care of the animal, but that is important for human health, either direct or indirect. So you're looking at nutrition, psychological well-being. So our animals feature as typical companion animals, and these are your pets, your pleasure animals such as horses, and working animals such as your guard dogs. And you can see these are commonly part of our environments. They're commonly part of the family. In most cases, that animal is seen as equivalent to a child. Then you also have the other aspect, our food production. Our production animal sector features quite diverse. You have from poultry, pigs, ruminants to fish. And this is where we get our milk, meat, and eggs. Think about it in a different light. What would your life be like with any one of these taken out? Can you think of your morning without coffee or with a snack? And this is where it all comes into play. And animal farming is divided into two sections. You have intensive farming, where you have high density of groups of animals together, such as a flock of 30,000 chickens together, or 100,000 cattle together. Or it can be extensive, where animals are on the range grazing. And that could be commercial farming or rural farming. And we have about 50% of the national herd in rural households. And here the farm is part of the family as well. That is wealth, that people interact with the animals directly. All in all, agriculture in South Africa is highly dependent on production animals. 30% of all farming in the country is pure animal, and 30% is mixed. That is because as a country, we don't have enough land for general plant production, and we also are water scarce. So farming features in the life of many South Africans. Then we have the aspect we don't really think about. We have our wildlife. Here we have animals in natural preserves and nature reserves, but we also have privately owned wildlife. There are more privately owned wild animals in the country than in your reserves, and they feature as entertainment in terms of hunting, tourism, but they're also part of food production. So all in all, animals have a direct impact on human health, which is where the One Health concept comes into play. So let's just look at the control of veterinary antimicrobials. Now this is extremely important because when you look at the medical side, we always talk about prescribing, doctors playing a role, pharmacists playing a role. The veterinary side, it is not as such. We have two acts. We have the Medicines Act, where your medical drugs are. Those are your prescription-only veterinary medicines and prescribed by vets, dispensed by vets. Not a major problem. The other act is the Stock Remedies Act. And this is where over-the-counter antimicrobials are available to anybody who can buy them, and they are freely available to most farmers. The act was designed, as the name says, back in 1936, to allow farmers to access drugs when there was no veterinary services in the country, and to also allow for treatment of animals when it was not cost effective to get out of vet. And this is where the majority of our antimicrobials in the country lie for animal use. If you look at the list, it's quite extensive. You have things such as tetracyclines, ionophores, sulfonamides, macrolides. And what's important is you have your drugs such as avoparcin, which is the same class as your linezolid. You have virginiamycin, which is in the same class as vancomycin. You have fosfomycin freely available. And being in the medical profession, those names should worry you immediately because you have farmers with direct access to drugs that create medical resistance. Then we have to look at the other aspect, food safety. Is our food safe? Is it protected in any way? And we have acts to control that, but we need to look at the effectiveness of that. So, in terms of how antimicrobials are also used in the veterinary industry, quite differs to medical. Now, everybody knows therapeutic. It's quite easy. You have an infection, you treat, and you should have a result. But think about this differently. We now have a farm of 30 to 100,000 animals. That farm is a patient. So you're using high volumes to treat a patient, which is an epidemiological unit. You also could use your drug prophylactically, where it's included to prevent disease because high density farming results in high disease spread. You get metaphylactic. This is where you treat both healthy and infected animals together with the intention of treating the infected animals but preventing the spread of infection to the healthy animals. And this is sometimes just impossible to do any other way. If you think about it, if you have a chicken house with 30,000 birds and just 5% are infected, how do you treat that house without treating the entire ecological environment? And that is where you have mass exposure of antimicrobials. Then the last one, which is most interesting, is antimicrobials are used as growth promoters. We heard about the microbiome. If you influence that microbiome, you actually get better feed efficiency and better growth in animals. And farmers have been using this for ages to allow for better carcass production. And it is one of the major use of antimicrobials in the world. So, in terms of the direct use, most veterinary antimicrobials are used empirically. Antibiograms and susceptibility testing is not a feature in veterinary use. Maybe a farmer will use a drug and wait 2 or 3 days to start, or wait for the results at least before they start changing, but you can't wait too long because you have a house and as soon as mortalities get out of control, there's nothing you can do. Then we have the route of exposure. We do have your parenterals, injectables most commonly, but most antimicrobials are given in the water and in the food. So we treat by ton, and this results in mass exposure of the environment. And once again, this could potentially impact on food safety. Now, if you go back to literature, one of the big scare points was when a study was done, and they said 80% of all antimicrobial growth promoters or antimicrobials in general were used in the veterinary industry. And this created the fear that the veterinary use of antimicrobials are driving resistance in the world. And this was a slide they produced in terms of the consumption. And it went a bit lower down, and AGPs are pretty much any drug used for growth promotion. In some countries, it's well controlled, and in other countries, it could be even the penicillins. And what they found out is that the United States and Asia were the predominant use of AGPs. 80% of all antimicrobials used in those countries are in the veterinary industry for food production. And this puts into perspective why the concern came about with veterinary use of antimicrobials. Thankfully, in South Africa, the veterinary industry cannot take any responsibility for the resistance we see. That is because of medical use. So this was a survey done as part of the report Natalie presented. It was the 2015-16 import data of antimicrobials. We don't make our own drugs in the country. And only 26% of all antimicrobials that came into the country in that year was used in the veterinary industry. So the medical profession is still the predominant use of antimicrobials in the country. So we have a slightly different dynamic in the country than elsewhere in the world. So what type of antimicrobials are used? We always thought that it could be mass amounts of antimicrobials, but if you look at it, the classes we would want to save are actually not used very commonly. You have about 1% penicillins, sulfonamides about 10%, macrolides 10%. The predominant use in the veterinary industry are your anticoccidials. Coccidial diseases are extremely important in intensive farming, they are not a class of drug associated with medical use because ionophores are extremely toxic in people. So once again, the veterinary industry does not use, at least the veterinary industry does not use a lot of your classical antimicrobials. So nonetheless, these antimicrobials have had a massive impact on the veterinary industry as on the medical industry. The first important take-home message, veterinary AMR is linked to veterinary use. Medical AMR is linked to medical use. The two do not meet. So the veterinary industry did not cause medical resistance and vice versa. They're completely different strains and we can show they are different strains. However, the concern is what happens. So we have migration of MICs in the veterinary industry. Thankfully, not as many escape pathogens on the veterinary side as on the medical side, but they do exist. We have Pseudomonas, which are really a problem, E. coli, but once again, created by veterinary use. In some countries in Africa, tetracycline resistance is up to 90% of all strains identified. The next important point is transmissible resistance. And these were these mobile genes that Natalie mentioned that we are concerned about. And we know that Virginiamycin was responsible for vancomycin resistance in some countries. Not all countries. In South Africa, it was never proven. Enrofloxacin, which is a veterinary drug, gets metabolized to 40% ciprofloxacin. So it promoted ciprofloxacin resistance in strains. We also have transmissible organs. Now, not many people realize this, but Staph aureus, or multiple resistant Staph aureus, is a zoonotic disease. It jumps from people to dogs. So here we had a case of dogs in households getting severely infected by people who had resistant strains. And we assume that it will jump back, but nobody has that conclusive evidence. Food safety is where we are predominantly concerned, because this is where you have small amounts of residues in the food, and this can still cause severe allergies in people. Penicillin-resistant, at least residues, are notorious for this. Then we have direct human toxicity. Some drugs like chlorphenicol has been banned for use in animals because we know it causes irreversible bone marrow suppression in people. The same can be for imidazoles, such as your nitroimidazole. We think they are carcinogenic, so they're not allowed to be used in the veterinary industry. Then we have the more worrying one, which is coming up more and more, which is transmission of the organism on the carcass, and that spreads your resistant determinants. And this is how colistin resistance spread. It was used as an AGP in China. You had massive development of resistance against the organism, and that resistant, your MCR gene, jumped from veterinary to medical. It's not the organism. And that is what we are concerned about, is the spread of your resistant determinants on our food. And you can think about it. You're handling that meat before you cook it. What are you doing in terms of exposure? Then lastly, we have environmental safety. We use an antimicrobial in mass volumes that can end up in the environment. Now, most people don't understand what devastating effect this could have. We're killing off soil and water microbes. Those microbes are responsible for what we call the detritivore cycle, the resumption or nutrients going back into the soil. Without that, you have a sterile environment and you actually kill off the environment, which means you can't use it for anything else. So the impact is not just on people, the impact is on the land and how we use land. So what mitigation measures were brought out on the veterinary side? Now, it is almost identical to the medical side. So the argument is you need to make a proper diagnosis before using an antimicrobial. Not always possible based on the size. So in the veterinary industry, we have a new way of dealing with it. Instead of isolation, we go the reverse. We go to biosecurity and vaccination. So you create a bio bubble to prevent an infection from getting in, as opposed to preventing an infection from spreading. These bio bubbles are so clean, I can guarantee that most of these farms, which are typically poultry and pig farms, are cleaner than the average house. If you enter into that farm, you have to shower in because you are the one bringing in the bacteria, not the animal. And this is how we want to manage farms to try and minimize the use of antimicrobials. Susceptibility testing as a general for screening is always been recommended, and restricted use where necessary, or preferably not use a medical drug when you can avoid it. Not very easy because there are very few antimicrobials that are not shared between veterinary and human use. Now, in terms of surveillance, Clinical surveillance in the veterinary industry is not considered very important because it's not done so much. What we are interested in is environmental surveillance. We want to know what your wild type strains are in the environment. So these are what healthy animals are carrying, so we can predict the future trends in resistance. Food safety is becoming a major important factor. Cannot oversize how important it is to follow good hygiene and good cooking practices when handling animal products, because a carcass could potentially be contaminated. A lot of classical toxicology that you would know that goes into medical testing is actually more extensive for drugs used in the veterinary world for production animals to prove that residues in the animal are not toxic to people. And if you look at the dossiers for food safety, they're more extensive than your medical dossiers. Because at the end of the day, if a doctor uses or prescribes a drug, it is informed use. If it's in your food, it is unintentional, non-informed use. Because it's non-consensual, at least non-consented, you have to have more protection. Then we have withdrawal periods. What level of chemical in the food is safe? I can guarantee whatever you eat has a chemical in it. So what we do is we set an ADI. That is your acceptable daily intake. That is the amount of chemical you can take in on a daily basis for the rest of your life without there being appreciable risk. It's a toxicology assessment, and we're assuming that it predicts entire safety. But nowadays, we also have to look at the impact of the microbiome. We know antimicrobials are not toxic in the pure sense, but by damaging the microbiome, it can cause secondary toxicity and unintended consequences. So nowadays, we have what's known as a microbial ADI. And here you have to prove that your chemical does not have an impact on human microbiota. They actually collect fecal content or colonic content, and you do cultures and you prove your residues don't have a direct effect. At the end of the day, food is safe because we test it. But what is food? In terms of toxicology, it is only classical food. So you're looking at muscle, liver, kidney, fat, milk, eggs, and honey. Everything else is not tested for safety. So red and white offal, which we know features in a lot of diets, is not tested for safety. We don't know what is present in those foods. We don't know how safe they are. Lastly, we have to look at environmental safety. And here what we nowadays do is called activated sludge. You collect bacteria from the environment and you look at the ability of your residues to kill off those bacteria. It is now so important, it is part of the NEMBA Act. Anybody releasing untreated waste into the environment, anybody, can encounter a fine of between 10 to 50 million rand. That's how serious we view contamination of the environment. In terms of the veterinary use, now because we know empirical use features a lot in veterinary more than in human use, we have what we call a differentiated use guideline. Most antimicrobials used in the veterinary world are divided into first, second, and third line. And this is just an example. This is from Scotland. South Africa has a different strategy, but more or less the same principle. What the suggestion is, stick to your first line drugs. If that doesn't work, ideally do a susceptibility test or move to the second category. The whole principle is to minimize the total number of drugs used to minimize the rate in which resistance develops. Internationally, there's been a lot of debate on antimicrobial growth promoters. They were used in the animal industry from the 1940s, unintentionally. Here we had fermented mash being used as food supplements. Later on, they found out the animals were growing better because it had chlortet and oxytetracycline in it as natural fermentation products. A lot of the world has decided that this is no longer acceptable and started implementing controls. As an example, the European Union has banned the use of any antimicrobial growth promoters except the anticoccidials. You're not allowed to even sell food to them from any other country if you don't have the same principles. And the idea is to minimize the amount of antimicrobials in the food. Not everybody has gone that way. South Africa is definitely not part of that list. If you go to the US, they're also not part of the list. But it is something the world is moving towards. And I think in 10 years' time, we will see a different trend in what is available in animal food. The next thing is, how safe is our food? Now, this is the stats from the last government report, which was 2016 roughly, looking at what they found in food. Very limited number of samples were tested, but you can see they already found antimicrobials in some of the food. So if you look at pork as an example, only 138 samples were tested, but you had an 8% positive reaction for antimicrobials. So we have to ask the question, how safe is our food? We don't know that answer. So all in all, what is the progress in South Africa in terms of proper stewardship? Unfortunately, not very strong. The last proper monitoring report was done in 2007, which was a Sandford report. Since then, not much. So we don't really know what the antimicrobial trends are in animal strains in the country. We have a few impromptu or non-structured reports, but all in all, this data is sorely needed, and we've been pushing the Department of Agriculture to do this. It's been a 5-year promise. Unfortunately, nothing much has happened. The residue monitoring program, Department of Agriculture once again runs. It is limited samples, so you have to ask, how protective is it? Is it really protective for a country where delicacies or red and white offal feature quite widely in our diet? And then the most important question, honesty. Now, what does honesty have to do with it? Now, if I go to a poultry farm where they're producing on average 100,000 eggs a day, and I use an antimicrobial, and I tell the farmer, for the next 10 days, you're going to have to dispose of all those eggs because they have antimicrobial residues. What is the answer? The usual answer is, where do you dispose of 500,000 eggs? Any idea? You crack it and you sell it to bakeries. So we have to ask, how safe are our confectionaries? Because we don't know what goes into those. The second thing is, if you go around in any part of the country, you see people selling food at the side of the roads, be it eggs, meat, fish. You ever ask the question, why is it on sale for so cheap? Where is it coming from? How contaminated is that food? And these are the questions we need to start dealing with in the country. We protect those that can afford it, but those that cannot afford it, we actually end up putting them in a more serious or severe condition. So all in all, there's a lot that needs to be done. The first step, and we are pushing for this, is for the over-the-counter use of antimicrobials in the country to be stopped. But the Department of Agriculture has huge opposition to controlling these drugs. They argue that farming and producing food is more important than the negative impact of residues. So that is where we need to push as a global One Health effort in the country, is safe food for everybody. With that, I will stop here.
Our next speaker is Professor Nicolette du Plessis. She's a pediatric infectious diseases specialist. She's an associate professor in the Department of Pediatrics. She's also the current president of the Federation of Infectious Diseases Societies of Southern Africa. And she's going to speak to us on antimicrobial stewardship in pediatrics. Thank you, Nicolette.
All right. Hi, everyone. Can you hear me? All right. Sorry about my voice. It's compliments from my children. If you can't hear, just lift your hands and I'll try and speak up. All right. So has any of you heard of the first 1,000 days of life? Have any of you heard of that concept? No? All right. So in pediatrics, the first 1,000 days of life is a very important concept because that is your first 1,000 days from conception to the age of 2. And with growth and development in children, that is an extremely critical time. Now, today I want to implore on you that I think as a group of pharmacists and doctors, we should look at the first 1,000 days of life in any child and try and make that antibiotic-free. And I do think that you're going to set that person up for a lot of success. And how do you do that? Well, we have some answers. We have to make sure that there's a safe pregnancy and delivery. We have to promote breastfeeding. I always want to say, any pharmacist, please remove formula from your stores. We have to absolutely promote breastfeeding in children, and we have to promote immunization. And if we get that right, in a healthy, fully immunized child with a common childhood illness, it's unlikely to be bacterial. It's unlikely that you need high-dose antibiotics or even antibiotics. It's unlikely to be resistant. And if you do prescribe, you should do that on specific age and weight-based categories. And if we do that right, I think we start off our first 1,000 days of life on the right track. So then looking at antimicrobial stewardship in pediatrics, we know that unfortunately antibiotics is the most common class of medications that we give to our children, and it's frequent in both inpatient and outpatient settings. And so it's antibiotic stewardship, you all know this, is then the practice of prescribing antibiotics only when it's necessary, the appropriate agents at the appropriate dose, duration, and route of therapy. And this is absolutely necessary, and I think all the speakers will allude to this today, to optimize clinical outcome and minimize unintended consequences of antibiotic use. So this is just, we think it's just a problem in developed countries. These are the antibiotic prescription practices in common childhood illnesses in low and middle income countries. And as you can see in respiratory infections, which is mostly viral, in countries like Uganda and Tanzania, close to 100% of these children get prescribed antibiotics. It's actually a travesty. In diarrhea, some more than 50% of low and middle income children get antibiotics. And even in malaria, and all of you know that antibiotics is not the treatment of choice in malaria, up to 40-50% in Namibia gets prescribed an antibiotic. All right. And we know this risk to the individual. Obviously, we all know this, and I'm not going to go through this slide because this is part of our main discussion today. What I want to focus on is the unintended consequence in children specific. This is beyond the development of resistance, looking at antibiotic adverse drug events. C. diff is obviously a potential, and I'm sure some of the adult physicians will discuss that. We know C. diff has got some sort of significance in young children where there's a high incidence of carrier rate, so it's difficult for us to look at CDI in children and specifically look at antibiotic use. But more than this sort of common things, and I think Natalie alluded to it, is what happens with our intestinal microbiome. Every time I prescribe an antibiotic to children, I look at their gut and I think, what on earth am I doing? All right. So, and the term intestinal dysbiosis should be first and foremost on all our minds if we prescribe antibiotics to young children. New data suggests that the potential for antibiotic exposure, especially early in life, can promote and affect the development of conditions such as juvenile idiopathic arthritis, inflammatory bowel diseases, asthma, and diabetes. All right, so they say that the way to a man's heart is through his gut. I want to say that the way through a healthy child is to preserve the gut. And that is by really, really making sure that you do not prescribe antibiotics to children unnecessarily. All right. And so the key principles, again, of an antibiotic stewardship program, I'm not going to spend a lot of time on this because this will be discussed in details further, but obviously you need to decide who you need to give antibiotics to, when do you need to give it, so the timely antibiotic management is a perfect tool, and for me, walking into a ward, this is my tool. You have two little lines and you sign and you date it. It's called stopping antibiotics, all right? The most powerful tool that you can have in a pediatric ward. Appropriate selection of antibiotics. What do you prescribe? All right, and then appropriate administration and de-escalation of antibiotics. So how do you prescribe it and how do you de-escalate it? Then obviously the use of expertise and resources. That's why we are all here, to use the resources to you available. And yes, you do need a pediatrician if you prescribe pediatric drugs. All right, my other pet hate is 5 mils TDS. Okay, in my mind, that doesn't exist. So if you see a script like that, please do not give that antibiotic until you're sure that that is the correct dose. Okay, and then obviously information. I think we will spend a lot of time on that, is how do you gather information and get that through up high, up low, disseminate it to actually review what you are doing. All right, so that's the general principles, and it's exactly the same when you're an adult or a child. But what is specific to inpatient antibiotic stewardship in children? You do have toolkits. We do have pediatric toolkits, the pediatric antibiotic stewardship toolkit is developed by the American Association of Pediatrics, and we even have our own written sort of guide. It's the book Infection Prevention and Control. That's part of the Better Care series, and Dr. Angela Dramowski is one of our dear colleagues that does a lot of work on IPC and AMS, and there's a section in this book about pediatric AMS in low and middle income countries. But it's important to have local guidelines. And if anybody that you phone say, I don't have a guideline, tell them no. There are clear pediatric hospital level guidelines. And if you don't know what you're doing, at least start with that. All right, we review it regularly. It's reviewed by specialist pediatricians. And I think that's a perfect sort of tool to start with if someone wants to know when they should be prescribing what to children. Okay. Then I like this handshake stewardship. Don't you love this word? All right. Is if you do want to prescribe antimicrobials to pediatricians, or to pediatricians want to prescribe antimicrobials to children in a hospital, what do you need? You need prior approval. So as they're prescribed, you're going to stand next to them, hold their hands, or this idea of post-prescription review, which is mostly what you guys would do in a pharmacy. So it depends on your resources. I think handshake stewardship or stopping pen stewardship is probably the best sort of teaching tool for young doctors. Obviously, telephone calls or notes in medical records is another way that you can do post-prescription review and feedback. And what are the pros and cons in a hospital setting? Obviously, there's lots of pros to have prior input to someone actually prescribing an antibiotic to a child. You can reduce unnecessary prescription. You can look at optimize the selection of the antibiotics. You can provide information very importantly on what you think they should do with cultures and diagnostics. And you can encourage, obviously, ID consultation. But the cons, and many doctors are going to tell you, you're going to only focus on the big guns. You're not going to actually teach them about the basics. And most people are going to say, this is a very sick patient with sepsis. I needed to start an antibiotic immediately. Everything is a crisis. And obviously, that's not going to be the case if you're going to wait for someone to stand with you if you prescribe an antibiotic. So there are obviously, with all of these sort of tools that we have, there are pros and cons to it. All right, syndrome-specific stewardship, I think this is probably one of the most powerful things in pediatrics, is to have a specific feedback and say, this patient has got community-acquired pneumonia. What do you know about it, and what do we need to prescribe? And we have similar syndrome-specific stewardships for skin and soft tissue infection, peri-op prophylaxis, and surgical conditions. And I think this is a nice tool for young doctors to learn when they should be prescribing what. Just of interest, if you do in the antibiotic stewardship programs, look at syndrome-specific stewardship, always remember the penicillins. Here I just talk about penicillin allergy. We obviously had penicillin outages, and we had to have specific recommendations for treating such as syphilis and things when we didn't have penicillins. So if we actually are promoting our first-line drugs, we should also have clear guidelines on what to do if you're allergic to it or if we don't have it. Otherwise, we just leave people in the dark. All right. What about diagnostics? We have a whole discussion on it, I think, in the second part today. So obviously, diagnostics is fantastic in inpatient care because it can facilitate antibiotic de-escalation. One of our pet hobbies, again, is stopping the vancomycin and prescribing Cloxa in a sensitive staph. People generally think we're crazy, but I mean, that we just all know, all of you know today that that is the way to go. Broadening therapy, obviously, if you work with vanco resistance, for example. Stopping therapy, I mean, our coagulate-negative staph is probably our most frequent pathogen in many of the ICUs, and that just comes to how cultures are taken, unfortunately, in pediatrics. And then obviously trying to identify viral etiology and not prescribing an antibiotics. But very importantly, before we implement rapid diagnostics in pediatric antimicrobial care, you have to develop guidelines for it. People have to know how to interpret it and how to use it. It really is important. And there's a big gap, I think, which all of us could actually focus on. Tests, sure, can be costly and sometimes resource intensive, but if you don't know what you're doing and what it means, It really is dangerous. And we saw it, you guys know, we saw it now with the COVID testing. Oh my goodness, the amount of antigen testing and what it means, it's just crazy because people do not know what positive predictive value means, what is a negative predictive value, what is the sensitivity of a test and the specificity of a test. And I think that's where we should really focus with diagnostics in antimicrobial care is what does it mean? What does the test mean? What does a positive and a negative test mean? And what should I do with it? All right. So, focusing then a little bit on outpatient care, we know that in pediatrics, many antibiotics are really prescribed at outpatient, and there are a little bit different core elements to outpatient antimicrobial stewardship. And it really is, we don't have that control on what they do as an outpatient. So we really need buy-in and commitment from doctors and nurses sitting in clinics. So unnecessary prescribing is a big issue with outpatient stewardship in children. And the examples is, non-specific upper respiratory infection, bronchiolitis, acute bronchitis, asthma exacerbation, conjunctivitis. These are one of the most common childhood diseases. All of us, I've got a respiratory tract infection at the moment. If I go to a GP, I can guarantee you I'm going to get an antibiotic, which I do not need. Okay? Don't you just love it? I had 3 courses of antibiotics and I'm still not better. Really? Okay. So when considering the epidemiology of bacterial infections, prescribing in the ambulatory setting that requires antibiotics, if you actually are cognizant of when it really is necessary, we can just decrease antibiotic prescribing by up to 30%, just by proper, again, guidance and teaching people that the common infections in children do not need antibiotics. Okay. And there, I also like this word, diagnostic stewardship. I think we have lost this COVID period. Many of our young students that do not have the diagnostic and clinical acumen to actually make a proper diagnosis. All right, so they can't make the diagnosis and therefore they just cover for whatever. Okay, so diagnostic stewardship is really, really important. When is it pharyngitis? When should I do a group A strep? When should I consider it? How should I test it? And what antibiotics is best? How do I look inside the ear? Do I have a pneumatic otoscope? Many people don't. What signs do I look for acute otitis media? A red tympanic membrane is not acute otitis media. All right, a screaming child and fever, sure, that will also be a red TM. All right. Pyuria, how do I demonstrate it? The easy use of a dipstick. I think people have lost that. All right, what's the signs and symptoms of a common UTI in children? And then obviously if I get to bacterial sinusitis, number 1, young children do not have sinuses as us. So I love GPs that diagnose frontal sinusitis in a 6-month-old. All right, doesn't exist. Okay, how do we make the proper diagnosis? And I think this is in pediatrics so important for me. We will have to teach our young doctors to actually have the clinical skill to make the right diagnosis, use the right rapid test, send it to the lab, have a proper relationship with the microbiologist and the virologist, and then decide on antimicrobial stewardship. We have to close this loop. Otherwise, we are never going to win the fight. All right, and obviously the antibiotic choice, broad-spectrum second-line antibiotics are often prescribed over first-line, and we really should stop that. I don't know who of you have been to private, but the amount of Oralox and cephalosporins that are now available orally that people prescribe. And it's the reason. Why is the reason? Because the viral infection didn't respond to Augmentin the first time. Yeah, you can't really fight against that. All right, and there's a particular challenge to actually go back to basics and basic first line. Obviously, the duration and the route of therapy is important. And here I want to just tell a funny story about Constantine units. Any of you have heard of the Constantine unit? All right, so Constantine in 321 BC decided that a work week would be 7 days. And from then, all of us that prescribe say 7 to 14 days, don't we? There's no evidence. All right. And so the question was asked by Noah et al. That if Constantine had chosen a 4-day week, would we all be prescribing 4 to 8 days? It should probably be better for antimicrobial stewardship. So be wary about your Constantine units in prescription. And then obviously be wary about outpatient IV antibiotics. Okay, so the measurements, I think you alluded to it, so I'm not going to actually spend time on that for the case of time. And you saw this lovely ring about the core elements of antibiotic stewardship. But I'm going to end with the gaps in pediatrics. I think to actually look at organizational structures and intervention and how we can put that into ambulatory settings in pediatrics is really important, and there's a big gap. How can we get people out there to prescribe antibiotics right? What's the cultural and adaptive influence of antibiotic prescribing? You know, antibiotic stewardship is not even a word in many of our languages. All right, how do we incorporate our nurses in immunization clinics, in well baby clinics? How do we actually empower them to be stewards? How do we do optimal treatment in common bacterial infections specific to pediatric populations, stating that an immunized child will unlikely have a bacterial infection, and it will, if they have, will unlikely be resistant. All right. How do we develop and actually measure pediatric antibiotic-associated harm scores? How do we teach our GPs out there to be self-stewards? And how do we incorporate the patient and the family in decision-making? Because if this mum stands in front of you, the worst thing would be a mother that says, I need you to prescribe an antibiotic. All right, so how do we get the mothers on board? And I think with that, I want to end the discussion. Thank you for listening.
Thank you, Nicolette. Our next speaker is Professor Marlene Cox. She's from the Department of Microbiology or Medical Microbiology, and her research expertise is on molecular epidemiology of important both nosocomial and community-acquired pathogens. And she's going to speak to us on clones and antimicrobial resistance. Thank you, Marlene.
Okay, thank you for the opportunity. Thank you for the invitation. So this is basically going to just elaborate a bit about the clones and what are their mechanisms that I carry around. So we had this very nice Lancet publication detailing the deaths in 2019 attributed to antimicrobial resistance. And it's really extremely high numbers. And then you will see that the deaths are mostly linked to 6 very important pathogens. So Streptococcus pneumonia is one of them. And I'm not going to elaborate on that pathogen. We know that we have very good vaccines for it. But I'm going to focus on the other ones of importance. But before I get there, I would like to just explain a bit about how do bacteria become resistant. So we've heard about these mobile genetic elements, and clones develop first through the process of selection, so selective pressure by antibiotics, but we also know that lots of the antibiotics were natural products, so they are in the environment, so you have environmental bacteria that are already resistant to that product. So they have those mechanisms, and bacteria like to share. So there are different ways. So first is chromosomal mutation. So we have a codon change, the genetic code change, ultimately the target change. The other ways are then transformation, and there we have pathogens like Neisseria that likes to take up DNA from the environment and make it their own. And that's why we have this problem with Neisseria gonorrhea that's developing, getting it from the commensal Neisseria, especially in the oral cavity. And then the others are those mobile genetic elements. Plasmids, we've got transposons, we've got phages. And all of that ultimately lead to these very resistant pathogens. But if we look at, what does it code for? Either it's non-enzyme mediated, so it basically the antibiotic cannot enter the cell, so the cell stops it from entering, or it's actively removed from the cell through efflux pumps, or the target is no longer available, so the antibiotic can no longer bind to the altered target. Then we've got our enzyme-mediated mechanisms, those beta-lactamases that are really giving us gray hair. And we have to remember that bacteria have more than one mechanism, so they can have enzyme-mediated as well as non-enzyme-mediated. So we have these groups of bacteria belonging to specific bacterial species that adapt and evolve over time, and they can survive in environments and they spread. And antibiotics basically provides that selective pressure for them to evolve and change over time. So it's an evolutionary process. And we have there the rise of the superbugs. First, we saw multi-drug resistant, where we have resistance to at least 3 classes. Next, extensively drug resistant, where we at least have 1 left. And then finally, pan-drug resistance, where we have basically nothing left. So I thought a good subtitle for this talk would have been Attack of the Clones. So the first organism is Acinetobacter baumannii. So this one is opportunistic pathogen, it's the environment, it persists in the hospital, and it causes large outbreaks in the hospital settings. So we have those two very strong lineages causing these outbreaks, global clone 1 and 2, and they have all their different subclones or clones in there. So we did this study, one of my students, where we got carbapenem-resistant Acinetobacter baumannii isolates from the private sector as well as the public setting. And what we found that from those 151 isolates, 140 of them were XDRs. And then 11 were pan-drug resistant. Really worrying. All of them oxycylinase 23, and that is just your plasmid-mediated carbapenemase. And through whole genome sequencing, we found a whole list of further genes. Important ones, there's your the NDMs, New Delhi metallobeta-lactamase, which really ultimately leaves you total resistance to your beta-lactams and your beta-lactamase inhibitors. And then it's got all those other ones that we find in Acinetobacter, and we have a lot of co-resistance, also plasmid-mediated acquired ones for aminoglycosides, tetracyclines, your metal resistance, as well as quaternary ammonium compounds. So when we looked at, so what are these clones, which ones we found that it's ST1 and ST2. Now globally, those are the ones that cause lots of the outbreaks and are known to carry these resistance mechanisms. So they are well established in our setting, same the rest of the country as well. They were a report from Cape Town, and those were linked to colistin resistance outbreaks. So basically for these organisms, we don't have much left. We tested some of the new antibiotics, Cefidricol, ampicillin sulbactam, and we already found lots of resistance to that also. Yeah, so, and this is what is so worrying. So it's not that we can say it's just in the private setting or it's just, so it's also in the public setting. Resistance are there. These organisms, and it comes with people. Now, Escherichia coli, the other very worrying one, as Prof. Shellac alluded to, ST131, pandemic clone, known to be ESBL producer, quinolone resistance. It has a plasmid-mediated quinolone resistance as well as chromosomal changes linked to quinolone resistance. And these are found in the community setting, so it spreads around in the community. Then these high-risk clones they transmit easily, they persist, and they cause recurrent infections. and they are really quite virulent. So they have lots of nice virulence factors that help them to invade and to cause infection. And then, so we focused a lot on urinary pathogenic Escherichia coli, and there are key sequence types or clones that are known to be associated and cause infections in patients. Note sequence type 410 that you will see it's known to be carrying carbapenemases. And that is extremely worrying if a pathogen like Escherichia coli in the community and it already has got that mechanism. What do we have left at the end? And then we have lots of emerging clones also linked to resistance. So in the clinical, the Escherichia coli that are linked to clinical infections mostly belong to phylogroup B and then D. But we also have some others that overlap. Some of those clones can be found in animals, but if we looked at such clones, they are quite different. So the animal ones and the human ones, they are not genetically related, so they are quite distinct. So in a UTI study that we did, we looked at isolates coming from a private laboratory for 1 week, and we found basically that 1 in 5 isolates were then ST131. And that's your multi-drug resistant clone. As I said, it's in the community, it's harboring a lot of antimicrobial resistance determinants, so that can be easily shared. And we know that ST131, if a patient goes home, the other household members will also get, most of them, lots of times they also get that clone, as well as then the animals of the house. So there's been lots of those studies. And then we also identified the other high-risk clones, ST69 and 73, which are also known as frequent causes of UTIs. So the next pathogen that I like to work on is then Klebsiella pneumonia. And we know this is really a worrying pathogen in the healthcare setting. So it's a normally found in the environment, in GIT, animals. But the problem with this organism is it also likes to acquire new information. So it likes to share genes. And that leads to outbreaks. And then we have the classical Klebsiella pneumonia, as well as the hypervirulent Klebsiella pneumonia. So the hypervirulent Klebsiella pneumonia is a bit different. Normally, it just caused infection or it is linked to infections in healthy individuals, more than in the community setting. And those pathogens are actually not known to be so resistant. So, but now, things change. So these clones that were normally thought to be not resistant have now also acquired some of the resistance mechanisms, making them hypervirulent as well as then resistant. We also now have antimicrobial resistant clones like ST11, which we know it's a resistant clone, but now it's also got another plasmid, a hypervirulent plasmid. So that is the problem, that bacteria can share all this with each other. So if we look globally at what do we see in Klebsiella pneumonia, we see clonal group 258, and that classically is the big one, known, initially described as the group carrying KPC, so Klebsiella pneumonia carbapenemase. And it's got lots of also progeny, so a bit more evolved was then ST11, 512, and then the other big one is clonal group 14. And I can tell you, these are also in South Africa. But in South Africa, the big one that we have is ST307. And this pathogen, or this clone, is linked to lots of different antimicrobial resistance genes and also carbaphenamases. So a whole range, from KPCs, initially NDMs, the OXAs, and VIM. And it's endemic in Italy, Colombia, United States, as well as South Africa. And it's important to know that this always harbors resistance mechanisms and other resistance mechanisms. So this clone initially evolved from being an ESBL clone, and when we started to use lots of carbapenems, it evolved to a carbapenemase resistant one, or a carbapenemase producing clone. And ultimately, they are saying, so this clone, looking at it, looking at the genome and trying to understand it more, that it's more fit and more able to, persist, and ultimately will replace 258 globally. So really worrying. And then another one that's a new kid on the block is ST147, also linked to lots of different carbapenemases. And this one is endemic in India, Italy, Greece, and North African countries. So luckily not yet here, but we know the borders, that they don't know borders, so it will get here. So basically, these antimicrobial resistant clones are just carriers, reservoirs for these antimicrobial resistance determinants. This is just to show you the nice image, the global distribution of ST307. You'll see the endemic nature of ST307 in South Africa. So we wanted to know, is this clone also circulating in the community? So we know it's in the hospital setting. And then we looked at UTIs in outpatients. And we found, yes, it's there. 35% of those carbapenemase producing isolates were ST307. Fecal carriage, so these were collected within 24 hours of being admitted to the hospital. Also 21% were ST307. So really worrying that we have this already circulating in the community. So the next one, which is really a formidable pathogen, is Pseudomonas aeruginosa. This pathogen has got an enormous genome, and it's got the ability to adapt to the environment using different metabolic pathways, so depending on the niche. And it's got inherent, adaptive, and then acquired mechanisms, which ultimately leads to the establishment of MDR and XDR, Pseudomonas aeruginosa, causing outbreaks. And these, when we look at these MDR and XDR clones or strains, they are normally high-risk clones. So it's specific clones that are successful and become established and then carry around these mechanisms. So if we look at, so in South Africa, we've got a carriage, the prevalence of carbapenemase producing Pseudomonas aeruginosa is about 21%. And we've got Pseudomonas with lots of different carbapenemases. So VIM, so we've got our class B enzymes, the VIM NDMs, also some class A, GES, but VIM very important in South Africa. And what's interesting, if you look at the spread of Pseudomonas and what are the different carbapenemase genes, it's to note that it's dependent on the specific gene, the carbapenemase gene that's endemic in that country. The Pseudomonas will ultimately develop that. So these are just key ones. Please focus on ST773, VIM2, and ST1111. Those ones are the key ones in our setting. So one of my students did this in a PhD. So basically just looking at the genome of colistin and or carbapenem-resistant Pseudomonas aeruginosa. And we found these NDM producers. And it's not common for Pseudomonas to carry NDM because it's very big, and they have to incorporate it on their genome. And we found in these isolates that she looked at that XDR was 2 out of 3 isolates were extensively drug resistant. And VIM2 most prevalent, and then we've got this dominant clone, ST1111. 2 out of 5 isolates were ST11, so spreading and carrying around the carbapenemases genes, but also having other genes. And then the final one, my colleague Prof. Ehlers, focuses more on Staphylococcus aureus and actually gram-positive pathogens. So she did this with her students, MRSA, burn and neonatal patients in 4 hospitals. And they found very important global clones, so pandemic clones that were basically established in the hospital settings. So ST239 is one of those. It's a known healthcare associated clone. And this one is also one of the most prevalent clones in the healthcare setting in South Africa. And they were there also over the years. So for ending off, so we local and national surveillance systems to track these clones so that you know what's going on in the different settings. Also, we need to know exactly what is the carbapenemase or the genes that these organisms carry, because that will influence ultimately the choice of the antibiotics, especially those new ones. And then we need good infection prevention and control strategies. Thank you.
Thank you, Marlene. As a pediatrician, those Klebsiellas scare me, beyond. I want to thank provisionally all our speakers, and then we're going to give time for questions and discussion now. Thank you very much. Are there any questions? There is a roving microphone for people to ask questions.
Thank you very much to the panel for the wonderful presentations. I just wanted to ask, when it comes to what impact is economics cost as a limiting factor to what kind of antibiotics we can get? Because I saw Prof. Sheldon had said that there are a lot of antibiotics in development, but what is the accessibility of those new antibiotics in developing countries? Because I saw with our study with cystic fibrosis patients that tobramycin is a good antibiotic for eradicating Pseudomonas in these patients, but a lot of public hospitals can't afford to use it, so they have to use other less affordable antibiotics. Thank you.
Is it on? Yes. So yes, that is the challenge, but in terms of what these new antibiotics cost, especially some of these new, the CA and CTs. But I think what is great about South Africa and in terms of the government sector is that cost and cost effectiveness are also evaluated, before recommendations are made as part of the essential drug lists or the EMLs. And when you have these drugs, like for example, tobramycin is a great example, because it has a better profile in terms of the aminoglycosides when compared to others. But then it is a better drug to use in some of these settings. But at least there are some motivation, you can motivate for some of those drugs. But the cost aspect of introducing some of these molecules are evaluated in terms of its efficacy as well before it's introduced in the public sector, which I think is actually a good thing, because some of these drugs we really do not need to use in our setting if we don't have specific and clear guidelines. And cystic fibrosis is a great example, because a lot of research has gone into tobramycin for that specific use.
Thank you. Gentlemen.
Can I just ask the other 2 students also just to stand up maybe with a mic so that we have faster access. Thanks.
Okay, thank you for the panel. I would like to ask on direct this question to Prof. Vinnie Naidu. Being also a passionate pet owner, there's a huge fashion drive at this point of time of a raw diet for dogs and cats. And the raw diet can be all shades of grey, from very good quality to very poor quality and everything in between. We see also DAF registered foods, but it's more of a quality control on the nutritional value of that. Are there any guidelines upcoming for that type of diet where the source of proteins and animal products are also regulated to be minimized of antibiotic use? Because this can also be a hot topic for resistant strains of bacteria to be passed on to family members.
Very interesting question. So in terms of animal food, actually in South Africa it's illegal to sell any food that is not registered. So a lot of these foods are illegal. Registered foods have to meet quality control in terms of nutrition, but they also have to be sourced from good sources such as controlled abattoirs. So there your bacterial contamination is taken into account. A lot of the food is contaminated, and we found out that when very often you have these cheap pet foods that are sold at garage shops, and you have mass mortalities resulting. So the quality of those are of serious concern. The good thing about dogs specifically is the bacteria on the food is not a problem because the GIT pH tends to kill them. But in terms of residues, they are just as susceptible.
While we're waiting for more questions, maybe I can ask Natalie a question, and it's around the pharmaceutical industry. It seems like every time they launch a new antibiotic or drug for that matter, that they want to establish the use of that drug or antibiotic before we can get out with our guidelines. And what is their buy-in into stewardship? I think it feels like we are just two different worlds.
Thank you. I think that's a great question. With the launch of ceftolozane, the CA and CT molecules, we were actually approached by the company that were going to launch it. There was a huge group where we tried to first establish guidelines, but then through all of the various processes that we as academics have to follow before we can even publish those guidelines, they just surpassed us. So the guidelines, for example, for those two new blicks is in press at the moment, but we've already seen a 368% increase in the use of CT. So I think we are not working in parallel, and I think it would be great to have a stakeholder engagement, and that's what we are trying to establish. I know FITSA is also trying to do that, and SARS is trying to do that, to say to all the drug companies before they launch a new molecule, please give the academics an opportunity, to look at it and to provide specific guidelines in collaboration with our microbiologists, and the genes and the clones that we have for prescribing this. So we are seeing some traction, but I don't think our processes are still also a little slow, but that traction there should be a little bit more motivation. And if that can come from, for example, the Ministerial Advisory Committee, that would be great, because I agree with you, it's not in parallel at the moment.
Thank you.
Do we have any online questions? Not at the moment. Yes, okay.
We are living in the era of pandemic. I was actually having a conversation with a student yesterday. Said they went to the GP with COVID symptoms and they prescribed antibiotics, which they felt kind of unfair. Do you have any information on the use of abuse of antibiotics within the context of the pandemic? Do you see a decrease in abuse of these antibiotics?
I'll start, and maybe my colleagues want to add. Is initially what we did see is there was a huge increase, and that's why I'm just sighing a little. of the macrolides, especially azithromycin. And it was, sometimes they prescribe it as a prophylaxis in case there's a secondary infection. And the macrolides, we know, also has an anti-inflammatory component. So when we started looking at some of these scripts, and we would ask questions, either the answer would be a secondary for in case, just that for in case there's a secondary infection, or we are prescribing it for its anti-inflammatory properties. So I suspect when we are going to do a surveillance again now, we will see, I don't necessarily think we'll see the beta-lactamase, the beta-lactams, the broad-spectrum beta-lactams still leading the group. I do think we may see, some differences in some of the classes that has increased. But yes, certainly, lots of antibiotics were being prescribed during the COVID pandemic. I don't know if my colleagues want to elaborate.
Nicolette?
Yeah, no, we had one of the big problems post-pandemic is food security as far as pediatrics go and antibiotic resistance. So macrolides are totally overprescribed, even in children. For some of our older bleaks like Augmentin is prescribed, and often together. So it's not just the overuse of one, but it's the co-prescription of many. Never mind on top of that off-label. I mean, you all know the story of hydroxychloroquine. And I mean, I had very astute professors that had a stash in their offices. And ivermectin rubbing on your chest that still has in their offices somewhere.
Or on your thighs.
On your thighs, yeah. So that is a huge problem, and unfortunately that's driven by, I think, a lot of social media and hysteria, because that is the reality that we live in. So the Google doctor in any pandemic is going to be larger and more powerful than evidence-based medicine. So it's still ongoing. I mean, we even had in hospitals physicians prescribing, and that's their standard. Would include 2 antibiotics. It would be anti-gout colchicine. It would be hydroxychloroquine. It would be everything. And in a sense, you do understand it because these patients are very sick, and there's very little you can do. And a lot of there was a high mortality rate initially. So I think, in a sense, we do need to be sensitive to that. I mean, we're making a joke out of it, and education, in my mind, is absolutely key. I think education really is the key to trying to prevent this.
Yeah. Justified. I think this is the first time that we as physicians were actually outscored by social media. I think many more people listen to social media rather than strong voices from academia. And I think this should be a lesson for us, that should we be confronted with something like this again, that we have clear guidelines from the start, that we get our patients away from Dr. Google, Facebook, Instagram, etc., etc. Did you have a question there?
So basically on the topic of education, I see under antimicrobial stewardship, under the goals, there's educating staff, but I'd like to know how you will be going about educating your patients, because I feel that you can do all the work in the upper levels of that, but if you don't get to the actual education part of the actual patients, it's going to fall a bit flat.
Natalie?
I think, and then I think Nicolette alluded to some of it in delayed prescriptions, but that is where a lot of our recent research focus has gone to, because as you've seen those mystery shoppers, many of those patients, when they were asking for urinary tract infection, on the third level of demand was, the first level of demand was, do you have something for me? The second level of demand was, do you have something stronger? And the third level of demand was, can you give me an antibiotic? And then they would give an STD because we don't have a lot of these words in all 11 languages. We found the sentiment that antibiotics clean your blood. in many of the statements. So I think there should be a bigger focus on education, on the microbiome, even starting in primary school. And that should be a process that follows. Then you can go on to, what Prof. Cox the more difficult parts of how resistance is conferred in later years and even at tertiary level if you found that you liked it. But I really do think that education should even start in primary schools because there's a lot of pressure. I mean, we can easily say the GPs are prescribing this, but some of the patients, when they leave the GP's practice or the pediatrician or whoever's practice and they come to the pharmacy and they'll give you the script, they'll say, and can you believe it? I just wasted 600 rands now and I didn't get an antibiotic. So can you give me an antibiotic? So that these misconceptions should be discussed. And the second aspect is we should look at linguistic. There's lots of linguistic barriers in South Africa and cultural barriers. And then just the last aspect, which Prof. Naidu spoke about, is trust and honesty. I think COVID has done a lot in terms of creating distrust between doctors and pharmacists, because some of the doctors would say, I absolutely am prescribing ivermectin. So then the patients are confused because amongst ourselves, we are not speaking the same language.
Yes. Sorry, just Prof. Naidu first.
So the odd thing is, on the veterinary side, the comment, what you hear is, you do not want to give me an antimicrobial. My doctor has given me an antimicrobial when I'm sick. What do you know? And we also have this professional mistrust between where they're using the professions to access drugs. And I'm pretty sure people get veterinary drugs for themselves as well. Ivermectin was a perfect example. A lot of the antimicrobials are available. So it goes further than that. And this is where the One Health concept has come in globally with the Tripartite Alliance, is we are advocating that as a combined profession, that One Health gets taught in primary schools so that it grows up. And what we have known is that kids who get taught properly teach their parents, and you break that cycle. And that is what we need to do.
Okay. Question from that side?
Yes, thank you for entertaining another question from my side. If I can come also in to play a bit of devil's advocate from the doctor's side in a practice, as being also a practitioner in private as well. We sit with a situation where professionals following different guidelines, not evidence-based, colleagues that's not even trained in evidence-based medicine from different spectra of age groups that share the same practice, there's already pressure amongst colleagues to prescribe certain medications. And then from another side is we deal with a very manipulative public where overworked doctors are practicing defensive medicine and don't want to risk being judged by colleagues and sued by public. So we are really in between a rock and a hard place. And if we can't agree amongst our fellow professionals, we feel we don't have the backing. Because at the end, we have to go through all the unnecessary case laws and being sued also by the public. So this is also a very needed aspect in private and public healthcare that needs to be dealt with.
Okay, I'm just going to briefly comment. We're going to discuss this afternoon, and I think the whole idea of antimicrobial stewardship creates a situation where when there are guidelines or guidance from, let's call it a more central institution, the pressure on the GPs, the pressure on doctors in hospitals will become much less, in a sense that they'll feel backed. You'll always have legal challenges, you'll always have outliers, but in general, if guidelines say I may not prescribe antibiotics and you tell that I'm just adhering to national guidelines, it will become easier. So I think there's a responsibility to us to make sure that these things happen. Until then, the public will keep on pressing. Okay, if there are no more questions, are there any online questions? No. Then we're going to break for tea. It just remains for me to thank all of us distinguished speakers for an excellent session. Thank you very much.
They said I must give it everything I've got, but you might have a few squeaks if I do, so I'm sorry. So welcome back for the second session. My name is Nicolette. So we're going to have 3 speakers that's going to take us through the organizational structures to support antimicrobial stewardship. We're going to look at the framework. We're going to look a little bit more at resistance, so what bugs we are working with, and how we make the diagnosis about the bugs, so biomarkers and rapid diagnostics. So I'm going to start this session by introducing our first speaker, Prof. Daniel Kokwana. He said I must say Prof. Q. Welcome. Prof. Daniel completed his BSc in biochemistry in Free State and then went on to complete a lot of veterinary degrees, which we don't often see here, MVSc, MEd Vet, and a PhD at this university. And he's a recognized specialist in the veterinary public health and registered with the South African Veterinary Council. And he supervises a lot of postgraduate students and collaborates with other researchers locally and internationally. And his area of interest is food safety, antimicrobial resistance, and determinants of health in us humans and also in animals. He's published widely, and he's associate professor currently at the Veterinary Epidemiology and Public Health at the Faculty of Veterinary Sciences at UP. He also serves at the Research Ethics Committee and heads a lot of MAC ministerial advisory committees on antimicrobial resistance. Thank you, Prof. Thank you for telling us about policy framework.
Yes, thank you. Good morning. I'm not sure if I'm audible. Yes, I'm going to try and be as short as possible. I think most of the policy and legislation have already been covered, so I will not go into too much details. So that's basically the overview of what I'm going to be talking about. Most of these documents are already available online, so it's just for you to kind of go through them in your spare time. But I'm just trying to make sense, help you make sense of some of the most important information in those documents. So I think in this picture before, where we're trying to project what's going to happen in 2050. And these are rough estimates in terms of 10 million people dying as a result of antimicrobial resistance pathogens. I think for me the most shocking part is the fact that 40% of this will happen in my home soil, in Africa. But if you look at the majority of studies and the majority of work that is being done, it's not done in Africa. The majority of work is done in developed countries. Even more alarming is that the data we use as Africans, it is based on the research done by people who are not from Africa. So in a sense, the policy framework and the legislations that we are implementing are foreign to Africa. Yet we'll experience 40% of the challenges that is coming in terms of antimicrobial resistance. So that is not all lost. So I want in the meantime to think, what should we be doing as Africans as we move forward to try to help our own situation in as far as antimicrobial resistance is concerned? What policy framework do we need to put in place to be able to address that? Now, there is a number of activities that are already going on. If you're from veterinary science, we talk about the OIE, and if you're from health, it's often WHO or FAO. So the 3 organizations decided to come together to develop what we call the Tripartite commitment in as far as antimicrobial resistance is concerned. And the idea here is that you realize that as you work more on the antimicrobial resistance sphere, is that there is this push not only from the health science in terms of the human health, but there's also a push from the veterinary science to think about this as a One Health approach. But I hope you are realizing from this slide here is that there is no indication of environmental health, which is one of the biggest problem that we're facing, is that there's limited work that has been done in that area. And even in our current situation in South Africa, we find ourselves there. And that's something that I will show you as I present it to you. So the idea of the tripartite commitment is to support all our efforts, both locally and internationally, in terms of putting in place some sort of framework to be able to deal with antimicrobial resistance. But that framework has to be relevant to our situation. And this is something that we as Africans or South Africa, we need to be working on, is that how do we make the framework more applicable to our situation in South Africa? Because our situation in South Africa and in Africa is unique. Some of the diseases that we are trying to deal with here have already been eradicated in most of developed countries. So we are dealing with a very unique situation. I mean, classical example is what we're discussing also from the animal side in terms of the use of antimicrobials, is that we are still finding ourselves with food insecurity, which is one of the major things that we need to be thinking about as South Africa. How do we deal with food insecurity at the same time deal with antimicrobial resistance? That's unique to us because most developing countries, they have things in place to be able to deal with that. So those are the three goals that this tripartite commitment was trying to achieve. Antimicrobial maintenance of efficacy, prudent use and responsible use, and access. Access is one of the biggest issues that we are struggling with. If we have antibiotics sometimes in Africa, they're the ones that developing countries or developed countries are throwing away because they have better ones. So that's one of the biggest challenges that we have. Also, we don't have mechanisms and laboratories in Africa to be able to manufacture our own antimicrobial. So that becomes a big issue going forward. Right, so after this whole discussion between the tripartite members, we end up with this global action plan, which has become famous. Everybody should know about the global action plan. So this global action plan was endorsed then by the World Health Assembly. So it deals with five specific areas. And you realize that, again, as you go into more details about the development of legislations and policy framework, is that they're all based on these five objectives. And we mentioned some of them earlier on. Knowledge, surveillance, use, sustainability. All those are the things that are key in us trying to deal with the issue of antimicrobial resistance as we move forward. Right, so in South Africa, we also made some effort to try to deal with antimicrobial resistance. And I think Prof. Natalie alluded to that earlier on. This issue of the antimicrobial resistance national framework, which is currently what we're trying to implement in South Africa to be able to deal with antimicrobial resistance. So this was a commitment that was made in 2014, and the strategy has changed a couple of times. So we had a 2014 to 2019 strategy on antimicrobial resistance. Now we have the 2014 to 2024. And then there's a number of interactions depending what information is available at the time. So in most cases, they call it a living document because there's new information that is coming in, there are things that needs to be added. And if you look at in the new strategy, which was not there before, is that the focus was heavily on human health. Most of the discussions were heavily on human health. Most of the guidelines, the direction to take was mainly focused on human health. So during the break, I was talking to Prof. Naidu, and I was saying to Prof. Naidu, sometimes when we sit down as colleagues, you realize that some things that you think are problems are actually not problems. I always thought veterinary science, we should be the one consuming like lots of antimicrobials, only to realize that we're just consuming a small portion of it, and the rest of it is in human medicine. So it further shows that there's a need for us to talk and to look at how do we move forward together. But there's a huge gap in terms of policy framework in antimicrobial resistance in crop production, a huge gap. And there's very few people that are working in that area to try to deal with antimicrobial resistance. And this is, for me, it's concerning because of the fact that for animals, from an animal point of view, the interaction between the animal and the environment is tightly linked. So it's something that we need to think about as we move forward. So this is the approach that we're trying to take, is to try to look at things together in terms of not separating human health, the environment, but to think about it in a one health, an interconnected approach. So in most cases, what happens in the environment influence what we see in animals. So our policy framework, it has to be designed in such a way that it takes this into consideration. And this is very key. It's not possible for the human health alone to deal with issues of antimicrobial resistance, and then we neglect the environment, then we neglect the veterinary area. So we need to be doing this collectively, and we should be doing it together. But so, as I said, there's a number of things and changes that have been implemented. The latest document is the 2017 document. There's now a 2018 document. And the thing that I wanted to highlight here is that the first guideline, it looked at implementation, and the only way that was there is that it was in South Africa. But now there's this one health approach and governance. So as we see the changes, where the problems, and identify areas that need to be improved, we work on those areas and then we add them to the document. So you can see it's changing and it's developing all the time. So this approach of one health is becoming more and more important. So what you prescribe in your practice, what we prescribe on the farm, we now understand that there's a interconnectedness that we need to be thinking about. And the issue of governance is another important thing that we are concerned about. So there's a number of departments that are involved in this activity, and they have their specific roles. But the entire strategy is really driven by the Department of Health. So under this Department of Health strategy, then we have the Ministerial Advisory Committee, which I serve with some of the colleagues. And it looks at a number of issues, but one of them is this optimization of our effort in dealing with antimicrobial resistance. And I think Prof. Natalie was showing you a picture about the different pillars that we are trying to look at. Yeah, so we want to look at those pillars not as individual professions, but look at those pillars from a one health point of view to make sure that everybody is covered. So the Ministerial Advisory Committee, specifically on AMR, I don't know if my picture is clear, but it reports directly to the Minister of Health, and there's also a provincial link to that one. So some of us do sit also on the Provincial Advisory Committee, And that Provincial Advisory Committee also supports the Ministerial Advisory Committee on AMR. And that's where, as physicians and other people at local level will be able to make contribution and good impact in as far as antimicrobial resistance is concerned. There is a number of other legislations that are in place to deal with issues of antimicrobial resistance. And Prof. Naidu was talking about, we call it the Stock Remedies Act, which is one of the biggest challenges from the veterinary point of view, because it allows for OTC, over-the-counter medication, and which is something that we need to look at as we move forward. How do we modify or enhance or deal with issues of antimicrobial resistance in as far as veterinary medicine and stock remedies is concerned? And then there's other legislations that I don't have to go into more details about them that underpins antimicrobial resistance, including access to drugs, which is one of the things, access to health, which is one of the things that I've mentioned already. Right, so how do we know that we are doing well? Recently, there's been a new development in terms of the monitoring and evaluation of the Global Action Plan. And there's a framework in place to be able to do that. And again, this is a tripartite effort to be able to deal with antimicrobial resistance. And South Africa has been involved a lot in terms of the last model, sending data to the bigger community. And if you go to the last website, you'll be able to see how we're doing in terms of individual pathogens and resistance profile. From the veterinary side, we are sending data to the OIE, looking at consumption level and use. And that information is also available online. So we are trying from the countryside to be able to implement some of the initiatives to try to contribute to a better understanding and monitoring of antimicrobial resistance. Now, so in conclusion, where do we need to go? Again, there is another strategic framework that is already available. That is a need for collaboration. If we're going to make some headways in terms of antimicrobial resistance. And this document was released last year, 2020, that outlines clearly what measures can be taken to be able to deal with antimicrobial resistance. But the bigger focus should be, we need to be collaborative in our approach. And I think that has to be a concerted effort from every profession in terms of dealing with antimicrobial resistance. Thank you very much. That's it for me.
Thank you so much, Prof. Thank you for your time. And if you have any questions, please remember to write it down. We're going to have an interactive session afterwards. All right. Our next speaker is Dr. Roxy Rule. Thank you so much. I think you're actually on maternity leave, are you? It's fantastic to have her with us. So Dr. Rule is a clinical microbiologist, and she's working here at the lab next to us at the NHLS. And she got a medical degree and her microbiology degree with distinction here at our university. And she's keen in the research in the field of microbiology, and she's also published, and her interest is antimicrobial resistance and stewardship. So thank you so much for being here, and you're going to talk about antibacterial resistance. Thanks, Roxy.
Hi, everyone. Can you all hear me? Okay, thank you, Prof, for that introduction. Yes, I think we've got a clear picture already today of what the problem we're facing with antibacterial resistance really is, but my talk is going to look a little bit more into detail at what the global issue is and some local data as well, and we'll briefly touch on the mechanisms driving this antibacterial resistance. So I think we've all established now that antibacterial resistance really is one of the leading public health threats of the 21st century. And these genes, as we've seen, occur naturally in the environment, but misuse and inappropriate use of antibiotics in humans, animals, as well as the agricultural sector is really driving this process. And it's postulated that by the year 2050, organisms with antibacterial resistance may kill as many as 10 million people per year. And unfortunately, the antibiotic pipeline is struggling to keep up with this global spread of resistance. So therefore, a global coordinated One Health action plan is really needed to address this impending risk. So I just want to talk a little bit about the World Health Organization Priority Pathogens List. This was released in 2017 to guide research and development of new antibiotics. And I think all of us here can appreciate the extent of the problem when looking at the Priority 1 critical pathogens list. These are organisms that we see frequently in our hospital environments, and they pose significant challenges to the treatment of patients that harbor these infections. So they comprise the carbapenem-resistant Acinetobacter baumannii organisms, carbapenem-resistant Pseudomonas aeruginosa, as well as third-generation cephalosporin-resistant and carbapenem-resistant Enterobacterales. Then we've also got the Priority 2 or high pathogens list. I just want to highlight there vancomycin-resistant Enterococcus faecium and methicillin-resistant and vancomycin non-susceptible Staphylococcus aureus. And then the medium priority 3 organisms, we've got organisms such as Streptococcus pneumoniae, which is penicillin non-susceptible. Now, looking at the mechanisms of antibacterial resistance, I use the escape pathogens as a framework to describe how these mechanisms occur, but really these principles can be applied to very many organisms. So the escape organisms are really those organisms are highlighted already from the World Health Organization Priority Pathogens list. They comprise Enterococci, Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, Enterobacter, and other members of the Enterobacterales group. So looking firstly then at antimicrobial inactivation, which I think most of us are quite familiar with, especially when it comes to the beta-lactams, is that of enzyme elaboration that then basically renders our antibiotics ineffective. So beta-lactam modification occurs through beta-lactamase production, which are enzymes that hydrolyze the beta-lactam ring, which is common then to all of the beta-lactam antibiotics. And these basically range from simple penicillinases through to cephalosporinases and ultimately carbapenemases as well. We also have other enzymes that inactivate other drugs, such as the aminoglycoside modifying enzymes, which covalently bind to these drugs, alter their properties, and then they cannot bind to their target site. Looking at another type of resistance mechanism, we have bacterial target site modification. I think most of us are familiar here with MRSA, where you've got a change in the penicillin binding protein 2 to penicillin binding protein 2A. When this happens, methicillin can no longer bind. It loses its affinity to that target site. In the case of vancomycin-resistant Enterococci, we see cell wall alteration, where there's a change in the peptidoglycan precursors that the glycopeptides bind to. So instead of D-alanine, it changes to either D-alanine D-lactate or D-alanine D-serine, and that affinity is lost for the glycopeptides to varying degrees. And then we also have methylation of the 16S rRNA subunit that will then encode for aminoglycoside resistance. Not depicted in this diagram is also fluoroquinolone resistance when you've got mutations in your DNA gyrase or topoisomerase genes PAR-C and GYR-A, and this can be chromosomal, or in the case of QNR acquisition through mobile genetic elements. Then in the case of gram-negative organisms, we see altered cell membrane permeability, which affects the way in which drugs enter or exit that cell. So porin alterations we see commonly in organisms such as Pseudomonas aeruginosa, where we have these structural porins that allow for the influx of micronutrients and macromolecules into that bacterial cell. But not only that, also antibiotics. And when these porins mutate, we see a reduced influx of specific antibiotics. And in Pseudomonas aeruginosa, typically the OPRD porin comes into play with imipenem resistance. And then additionally, we have efflux pumps that actively pump antibiotics out of the cell before they're able to exert their effect. And these efflux pumps can confer resistance to not only single classes of antimicrobials, but multiple classes. And then finally, we have persistence through biofilm formation. So this is when bacteria aggregate in communities, and they're able then to alter their metabolic state. So drugs such as the beta-lactams that require actively replicating bacterial cells are less effective. Additionally, they secrete extracellular matrix, which entraps these communities, which means then that antibiotics and environmental stresses, etc., are not able to penetrate that community adequately enough to eradicate those organisms. But then also we've heard about horizontal gene transfer, and this occurs readily in these environments where they're able to share not only virulence genes, but also antibacterial resistance genes. So the problem that we face is really multiple organisms do not only have single mechanism at play, but rather multiple mechanisms of antimicrobial resistance that then confers not only high-level resistance to specific classes, but also multi-drug resistance and extensive or pan-drug resistance in those organisms. So then looking at some of the epidemiology, Prof. Koch already mentioned this article, which is a very interesting read, and I would encourage everyone to look at it. It basically describes the global burden of antibacterial resistance in 2019 and was recently published in The Lancet this year. So the framework of my presentation going forward is taken out of this article. But then to look at some local data, I looked at the 2019 Germs SA National Surveillance Report as well. So looking at global death rates, in the study from The Lancet in 2019, they looked at attributable death rates as well as associated death rates. And what they mean by that is that deaths that were attributable to antimicrobial resistance is all those patients that died with an antimicrobial resistant infection that could have been avoided had that infection been replaced with a drug-susceptible infection. And then associated is those patients that died that could have been avoided had that antimicrobial resistant infection been replaced with no infection. So in 2019 then, they estimated that 1.27 million deaths were directly attributable to resistance, and almost 5 million deaths were associated with resistance. So you can see we're already well on our way to that 10 million death rate target that they've postulated for 2050. Now, unfortunately, as already seen in the previous slides by Prof. Q, the highest burden is in Africa, and you can see that in the green bars in the image there. And southern sub-Saharan Africa is highlighted in red with still a substantial mortality. Looking then at the infectious syndromes further, you can see that lower respiratory tract infections, bloodstream infections, and intra-abdominal infections contribute to the vast majority of mortality cases. And this is about 78.8% of the estimated deaths in this time period. And then Prof. Koch already highlighted this slide with the pathogens, but I just want to show you again that the World Health Organization priority pathogens list critical organisms really feature in the top 6 already, as does Staphylococcus aureus, which is a category 2, and Streptococcus pneumoniae, which is a category 3. So we can really appreciate why these organisms feature on that World Health Organization list. Together, these 6 pathogens contributed to 73.1% of deaths attributable to antimicrobial resistance and 72.1% of deaths associated with antimicrobial resistance. Looking at sub-Saharan Africa, the highest burden of deaths attributable to antimicrobial resistance was due to Klebsiella pneumoniae at 19.9%, followed by Streptococcus pneumoniae at 15.9%. This is a bit of a busy slide, but then just again to highlight the attributable deaths due to pathogen-drug combination. And if you look, carbapenem-resistant Acinetobacter baumannii contributing to 57,000 deaths, Klebsiella pneumoniae, third-generation cephalosporin-resistant to 50,000 deaths, and carbapenem-resistant to 55,000 deaths, and Pseudomonas aeruginosa carbapenem-resistant to 38,000 deaths. So substantial mortality associated with these organisms. And then MRSA there at 121,000 deaths in this time period. So then just to look at a few specific organisms, I can't, unfortunately, in the interest of time, go through all of the organisms, but I picked a few that are relevant to us in our setting. So looking at extended spectrum beta-lactamase producing Klebsiella pneumoniae, you can see South Africa having very high rates. This is about 70 to 80% of our isolates. And this is a problem because we're not only seeing it in the hospital environment, but communities as well, which really makes treatment difficult. And it forces us almost to use our carbapenems empirically, which is not something we really want to do. Then moving on to carbapenem-resistant Enterobacterales, or CRE. Klebsiella pneumoniae CRE is by far the most prevalent isolate globally, or organism globally. And we're seeing an increase in severe infections caused by this organism globally. And this is driven by the ST307 clone, which Prof. Koch has already touched on. And this specific clone is successfully disseminated across every major continent, and it's demonstrated extremely high transmission rates in hospital settings as well. And as mentioned, it comes with various other antimicrobial resistance genes as well. Now, looking at some national data from 2019, you can see that our CRE rates are on a steady increase. In 2015, bacteremic cases across the 4 provinces evaluated was only 117. This has now subsequently almost increased tenfold to 1,052 in the year 2019, and I'm sure this figure is much higher now. And looking at Gauteng, you can see that we bear the highest burden at 64% of cases. Patient outcome in this specific survey was known for 96% of patients, and a staggering 38% of these patients died. Another reason why you can see that this organism, or this group of organisms, features on that World Health Organization list. There's limited treatment options, and they carry with them a very high mortality. So we know that our carbapenem MICs dictate our regimen choice when we're dealing with CRE infections, and literature suggests that when the MIC exceeds 8 to 16, the benefit of adding a carbapenem to that regimen is questionable, and it forces us to look at other active agents. And unfortunately, looking at our data, you can see that we've got very high rates of carbapenem MICs in excess of 8. Meropenem looking at about 50% that are more than 8 micrograms per mil, and imipenem probably around 30 to 40% of our isolates. So this forces us to look at other agents, and unfortunately, with the acquisition of carbapenemases comes the acquisition of other antimicrobial resistance genes that are harbored on those plasmids as well. So often, our agents like aminoglycosides or fluoroquinolones may also be non-susceptible, which makes it then even more difficult to treat. So in 2018, 6% of our CR isolates were also found to be colistin resistant, and we've seen other data from Prof. Shellac that showed a shocking 18% figure for the most recent data. And we know that we, especially in the public sector, rely on colistin as part of our treatment regimen. So without this agent and with this combination of very high carbapenem MICs, we're really in a lot of trouble. And if you look at the organism profile there that harbors the colistin resistance, again, Klebsiella pneumoniae features as the predominant pathogen. Now, looking at the specific enzymes that are at play in this environment, we see that the OXA48-like and NDM enzymes are by far the predominant enzymes that we see within our CRE isolates. And again, Klebsiella pneumoniae is the organism that harbors these most commonly. Looking at local Tshwane Academic Division data, which is unpublished, Klebsiella pneumoniae is also our major pathogen when it comes to CREs. And in data from an ICU study that's currently underway at Steve Biko Academic Hospital, we've seen a 15% CRE positivity rate in our patients. And unfortunately, 90% of these patients contain NDMs, and this is problematic because even the new drugs do not actually cover these enzymes. So we're seeing that the new beta-lactam-beta-lactamase inhibitor combinations might not be effective. Additionally, these enzymes harbor very high carbapenem MICs generally, so again, difficult to treat. And even more problematic is that up to 20% of them are showing dual OXA48-like and NDM enzymes. So just looking back at the Lancet study, looking at our picture in comparison to the rest of the world, with carbapenem-resistant Klebsiella pneumoniae isolates, you can see that South Africa is sitting at a rate of about 5 to 10%, which doesn't sound that bad, but when you think about the mortality associated with it, it really is still a massive, massive problem. Moving on then to carbapenem-resistant Acinetobacter baumannii, approximately 45% of all global Acinetobacter baumannii isolates are considered to be multi-drug resistant, so resistant to 3 or more classes of antimicrobial agents. And we're also seeing an increase in pan-drug resistant strains globally as well. Looking at our picture, you can see quite an ominous picture there, with 50 to 60% of our isolates being reported to be multi-drug resistant, or carbapenem resistant rather. And again, from our national data, you can see here that most of our isolates, less than 10%, remain susceptible to cefepime and the carbapenems, which means then that we have to turn to agents like colistin, especially in the public sector. And what I want to highlight here, although most of our isolates still remain susceptible to colistin, you can certainly see a decreasing trend from 2018 to 2019, which is very concerning. In this period of study, 1,438 cases of carbapenem-resistant Acinetobacter baumannii bacteremia was documented. And again, Gauteng suffered the highest burden at about 55% of cases. Outcome data was known for half of these patients, and 60% of these patients died in hospital. So really, really shocking to think that this is what we're dealing with. And as a patient, certainly you don't want to end up with this when you become or have to be admitted to hospital. Then finally, looking at methicillin-resistant Staphylococcus aureus, the emergence and spread of MRSA has been a consequence of widespread penicillin use. And looking at South African data, we've got estimated prevalence of about 30 to 40%. And just to bring in a bit of the One Health approach here, there is also livestock-associated MRSA, which is especially prevalent in Europe in the pig industry. And they are now also reporting substantial contributions of these strains to hospital-acquired infections in Europe as well. So just to highlight again why a One Health approach is really necessary when dealing with antimicrobial resistance. Fortunately, in the South African setting, our MRSA prevalence does appear to be on a downward trend. Data from 2010 showed a 53% prevalence, and the most recent data that I could find is from 2016 to 2017, showing an estimated 24% prevalence across Gauteng and the Western Cape regions. So in conclusion, antimicrobial resistance in the Lancet publication was found to be the third leading cause of death in 2019, second to ischemic heart disease and stroke. And we've seen now, I think, from the various talks that we've had, that this resistance is a major threat, not only to global health on an individual level, but to economic growth as well as food security. So therefore, I think this further promotes why we need this coordinated global One Health effort to combat this problem. And we shouldn't only be directing our efforts at research and development of new antimicrobials, but we should be looking at multiple other prongs as well. So key areas of focus we should be considering includes infection prevention control principles, not only in the hospital setting, but in the environment as well, through water, sanitation, and hygiene efforts. We need to be looking at prevention through vaccination, and a key example there is Streptococcus pneumoniae. We should be enhancing vaccination efforts. We should be looking at research and development to new vaccines, that cover these other multi-drug resistant pathogens as well. We should be reducing exposure to antibiotics unrelated to human disease. We know the farming industry contributes to antimicrobial resistance. Antimicrobial stewardships within hospitals and, very importantly, outpatient settings as well. And then finally, research and development of new antimicrobials. But not only the traditional antibiotics, but thinking of other outside-of-the-box concepts such as bacteriophage therapy or biological agents. All of these things could contribute to combating this problem of antimicrobial resistance. And with that, I thank you for listening and enjoy the rest of the day. Thank you.
Thank you so much. Thank you, Roxy. All right, so our third speaker and our last speaker before we start having a fruitful discussion is going to be Dr. Mohammed Saeed. Welcome, Dr. Mohammed. Dr. Saeed is a clinical microbiologist, also here at the NHLS and Tshwane Labs. He's a senior consultant in the department since 2016. He did his undergraduate at Wits and then his specialist training here with us at Pretoria. And he's now also a training specialist in science students. He serves on numerous committees as well as pharmacy and therapeutic committees at Steve Biko, which is our big hospital next door. And he's published quite widely, especially in the field of rapid diagnostics, Group B, strep disease, and infection prevention and control. And lovely to have you here and looking forward to your talk.
Thank you, Professor Annette. Good afternoon, everybody. It's a privilege for me to talk to you today, and I'm going to be talking to you a little bit about the use of biomarkers and rapid diagnostic tests in antimicrobial stewardship. The outline of my talk, now when I'm going to be talking about rapid diagnostic tests, the sort of latest change that's happening in the clinical microbiology lab is the development of rapid molecular tests. So I'm going to be focusing more on your rapid molecular tests, particularly your multiplex PCRs and its effect on antimicrobial stewardship. With regard to biomarkers, I'll talk a little bit about the biomarkers, but in particular, we'll concentrate on PCT, procalcitonin. We'll look at the evidence for it, and then we'll conclude from there. So the future microbiology lab is going to be changing. There's going to be rapid molecular diagnostics, and I think that in time to come, the traditional culturing that used to happen in microbiology labs is going to fall away and is going to be completely replaced by molecular tests. And this is important because if you've got a quick answer to what you're dealing with you can institute appropriate therapy, and if it's present in an emergency department or casualty setting, you can decrease your hospital admission rates. In the hospital, you can decrease your hospital admission stay, and there will be a decrease in inappropriate antimicrobial usage. Now, these multiplex tests allow for syndromic testing. So, for example, if you have a patient with respiratory symptoms, you will then apply respiratory panels or multiplex, which contains all the prominent pathogens that cause respiratory tract infections, for example. Now, in the next few slides, I thought that the best way for me to capture the impact of these rapid molecular tests is to share with you this real-life case that happened, that was seen in our very own setting, and hopefully, we can see the importance of these rapid molecular tests. And I know there's clinicians and pathologists here that can, I'd like you to interact with me in this case when we go through it. So the case is of this 49-year-old patient who's admitted to surgical ICU. He's been there for about 17 days, and as you can see, he's now starting to develop some features of infection. He's got a temperature, tachycardia, inflammatory markers are rising. Quite correctly, the clinicians, what they did was that they said, right, let's change his deep lines, let's change the urinary catheters. They sent in some samples to the laboratory, and what they sent in was respiratory samples and 2 sets of blood cultures, which is fair enough, that's decent. Of interest, when he was first admitted to the ICU, he had a swab taken, and he was found to be positive for OXA48 carbapenem-resistant enterobacterialis, or CRE. On initial admission to the ICU, we don't know what that indication was, but he was put onto piperacillin tazobactam, and he completed 7 days then, responded well. Now, in view of him being 17 days in the ICU, and now he's developing features of infection, what would be your next step in this area? I don't know, any of the micros or pathologists or clinicians want to have a go at it? What would be an appropriate step here? Would you start him on a carbapenem? He did well on the piperacillin tazobactam last time. Would you want to leave him on that? Or one of those other options? Anybody want to have a go at it? No takers? Okay. If you look at our setting, I mean, you wouldn't be wrong to go with A, where you start a patient on a carbapenem empirically. Because, you want to cover for ESBL organisms, you want to cover for Pseudomonas, and we know that, so this was, as I said, in our setting, so, it would depend on your epidemiology as well, but a carbapenem wouldn't be a bad choice to go empirically here. So, you was started on a carbapenem, the blood culture flags after 3 days, the microlab phones and says we've got a GNB, or gram-negative bacilli, on the blood culture. So this patient, the clinician said, right, let's continue him on meropenem. And you'd agree with me that that dose is quite sufficient, 2 grams IVI, 8 hourly. It was given as an extended infusion. And he was continued. But you'll see they continued to deteriorate. And what they decided now was that, he did have that CRE on admission. So let's start him now on colistin in case the GNB we're dealing with is an Acinetobacter or a CRE organism. He still continued deteriorating. And then what happened? Now you add linezolid, mycofungin. Okay, could be accepted. I mean, you've got a sick patient, nothing's happening, you're now throwing everything at the bug here. So this is what happened. The laboratory phones again after that, and since there's an NLF or non-lactose fermenter on the plates. However, shortly after that last escalation, unfortunately, that patient demised. Now, what was the pathogen in this case? Yeah, very good. Yeah, so the organism here is Stenotrophomonas multifilla. This is an organism, multi-resistant organism, is only sensitive to cotrimoxazole, or Bactrim as we know it. Now, the point that I want to highlight is that this patient, if we had and I want to introduce you to this assay, which is called the BioFire Blood Culture Identification Panel, or BCID2 panel. So this is an assay that you can do on a positive blood culture, and you have an answer within 1 hour. So it's got a wide range, as you can see, the gram-positive, gram-negative. It picks up yeasts, and it also picks up antibiotic-resistant markers, particularly your carbophenamases that's picked up there. And if you look at the gram-negative bacteria, the last organism there, Stenotrophomonas multifila. So what I'm saying is that in this case here, you know, when that blood culture flagged positive, we could have had the patient on cotrimoxazole in an hour's time. It would have been, I think, would have altered the cause of this patient. You know, the outcome would have been better. You would have saved on antibiotics, right? We use meropenemir, colistin, linezolid, mycophangan. It would have been good for antimicrobial stewardship, and it would have been good enough fight against antimicrobial resistance. So this is the importance. I thought this case highlighted the importance why we need to incorporate these into our workflows in the laboratory. So you know that the traditional method was that we get the blood culture bottle gets incubated. When it flags positive, we put it onto plates, we grow the organism, then it goes for an ID, then the result is authorized. If everything goes well, 24 to 48 hours, oftentimes we have mixed cultures, we have contamination, and that can go up to 72 to 96 hours to get a result. And you saw with the molecular test, as I said, 2 minutes of hands-on time, right? And result in 1 hour. So this is just one of the assays that I'm speaking about. There are many other brands or molecular assays, but this is the one that I've chosen because we've got some experience with it. So how good does this blood culture identification panel work in the adjustment of empiric therapy? And this was a study done by our own Dr. Rule here, sitting here. And this was done in our setting, which is at Steve Biko Academic Hospital. And what it looked at was that we looked at how it will work in critically ill patients. And there were 78 positive cultures from critically ill patients. And the turnaround time, there was a faster time of communication of results. And have a look at that, with a mean of 2 days, 3 hours, and 17 minutes faster that we could have given a result. So, and this was actually found in many studies that this is actually the case. Most studies found that you can get a significant reduction in the time in which you can get a result to the patient. Therapeutic advice given much faster, as you can imagine, and there was an adjustment of treatment in 32% of patients. Now, what we used in this study was the BCID1 panel. I'm sure that if we use the BCID2 panel, which has got many more targets and antimicrobial resistance genes, that 32%, I'm pretty sure, would have been much higher. So the conclusion was that the use of this blood culture ID panel is supported as an adjunct to culture methods. At this point in time, we can't get rid completely of the culture methods because we require the organism to give an MIC to report to the clinician. So these molecular tests don't give you an MIC. It picks up resistance mechanism or targets, but doesn't give an MIC. So culture will still be there, but I think it's essential to use this as an adjunct. Why is there a move towards those molecular tests? Obviously, they have higher sensitivity and specificity in recognizing the pathogens. The other positive is that there is a detection of multiple pathogens. Now, this can actually be a double-edged sword because, number one, you may pick up polymicrobial infections because it's so sensitive. So that's a good thing. But on the other hand, sometimes in your gastrointestinal panels or your respiratory panels, you may find you pick up the colonizers because it's so sensitive. You pick up 3, 4, 5 organisms there. What do you do in that case? So my feeling there is that although this can be a point of care test next to the bedside, I think this should still remain a laboratory test because this can be then discussed with your pathologist or microbiologist who can look at certain parameters in the lab and try and advise which is a pathogen and which is a colonizer. That's why I think there should be a lab-based test. But the greatest value of this is the rapidity with which you get the result. And that's what I tried to establish in an earlier slide. Okay, so I'm going to move over now to talk a little bit about the biomarkers and acute phase reactants. And this is a group of proteins that increase in response to inflammatory stimuli. So this inflammatory stimuli can be infection, can be trauma, autoimmune diseases, can be neoplasms. All of these things can result in an increase in the inflammatory markers here. I've got some examples that's listed there. That's not an exhaustive list, but there's some of them that I listed there. The ESR, just note, is a non-protein acute phase reactant. Now, in the hospital setting, the usual workup will include CRP, white cell count in general. And the reason for that is because of its cost effectiveness. It's much cheaper than some of the other biomarkers. But the problem with it is the ambiguity regarding the use of antibiotic treatment. That's what's causing that increase in things like CRP and white cell count. Is it infection? Is it something else that's causing it? So there is an ambiguity. And the chance is that you can give unnecessary treatment, and unnecessary treatment results in antimicrobial resistance. When you've got unnecessary treatment, you've got a person at risk of C. difficile infection, prolonged hospital stay, prolonged IV use, prolonged or chances of changes in the microbiome of the patient, as was discussed by the other speakers earlier on. So therefore, the evidence is there to support the use of PCT or procalcitonin to improve diagnosis of bacterial infections, and beyond that, even for the resolution of infection. Very quickly, what is PCT? Biomarker of activation of the innate immune system by bacteria. Why specifically bacteria? The reason is that the stimulant to the production of PCT are cytokines, which are produced when the body comes into contact with components of the bacterial cell, for example, polysaccharide, peptidoglycan. Then it stimulates the production of those cytokines that I've listed there, and that drives up the production of PCT. The PCT also arises much earlier in response to bacterial infection, within 4 to 6 hours, whereas the CRP lags behind quite a few hours later after CRP. And importantly, the elevated PCTs are not seen in other non-infectious inflammatory conditions. I want to just highlight this study here that looked early on at the difference between PCT and CRP as markers of bacterial infections, and your PCT level, as you can see, was more sensitive and specific as opposed to CRP. Okay, so the advantages of PCT: it can distinguish bacterial from viral infections. That's what I discussed in the previous slide. It will determine if there's colonization. So in colonization, you wouldn't get a rise in PCT, so that can happen. The test, once received in the lab, within 2 hours, you can get a result. The faster turnaround time, and it can affect the way you're going to treat this patient. And it's also an indicator of source control. If you do serial PCTs, you can see whether your treatment is working. This is a nice diagram just looking at the evidence of PCT and its benefit for antimicrobial stewardship. And you can see that on your, is it your left? There's quite strong evidence, 3+ evidence for its use, and its positive impact on antimicrobial stewardship in a number of common infections in hospital: meningitis, pneumonia, upper respiratory infections, sepsis. And there is also evidence for its use in a variety of other conditions to have a positive impact on antimicrobial stewardship. If there's one trial that I'll need to speak about is the so-called Stop Antibiotics on Guidance of Procalcitonin Study, or the SAPS trial. And this is a landmark trial which was done to look at the effect of PCT. Now, this is deliberate. Note my colors there. It's taking the SAPS uniform as well. So this is a SAPS study. So that's why I've chosen those colors there. But this is a randomized multi-center trial that was took place in the Netherlands. And the aim was to analyze whether you have daily PCT measurements, so that's the PCT guided group, versus standard of care approach. Can it safely shorten antibiotic duration in ICU patients? So it was a large number of ICU, critically ill patients that were included in the study. And the PCT arm, what was the intervention? The intensivist stopped antibiotics if your PCT level decreased by 80% or more, or the absolute measurement was below 0.5. And the findings is that the median duration of antibiotics in a PCT-guided group was shorter as compared to the standard of care. So you've got great for antibiotic stewardship, great to reduce exposure to antibiotics, and great in the fight for against antimicrobial resistance. And a further interesting or additional finding was that the mortality in the PCT-guided group was also much lower or lower than the standard of care group. So the PCT guidance stimulates reduction in the duration of treatment in critically ill patients. And the last point, the PCT guidance leads to improved diagnosis and treatment of bacterial infections. And that's the cornerstone of antimicrobial stewardship. No talk would be over without us talking about antimicrobial stewardship, biomarkers, and COVID-19. And I think there was a question early on about this as well. And that is that it's very difficult to distinguish between COVID pneumonia and bacterial pneumonia. And in fact, severe disease, it actually looks like a person with or bacterial sepsis if you have a severe COVID patient. Now, unlike other viral respiratory infections, only 8% of COVID patients were found to have a co-infection or bacterial co-infection. But on the other end, up to 72% of patients who came with COVID were put on antibiotics. Now, here is where the role of PCT may come in here, because PCT is going to be effective in this case in reducing unnecessary consumption, because many studies have shown that infection with COVID-19 doesn't increase your PCT levels. So if your PCT levels are increasing, that is suggestive of secondary bacterial infection now. And a study had shown that if you look at a cutoff of 1 nanogram per ml, that's got a positive predictive value of about 93% to show that that's secondary bacterial infection. Also importantly, some of the drugs that are used to treat COVID-19 include dexamethasone and tocilizumab. These are all dampen the inflammatory response. And if you're going to use CRP as a marker, that's going to be dampened by these drugs. But PCT doesn't get affected. So even if you get a secondary bacterial infection on those drugs, your PCT level will still rise. I'll just end off by looking at a cost impact of PCT-guided antibiotic stewardship. And this was a US study that looked at cost impact. And the objective was to compare what the effectiveness and cost of a PCT-guided algorithm versus a standard of care. And as you can see there, PCT-guided treatment, you get reduction in antibiotic days, shorter length of stay, shorter length of ICU stay. All of these lead to a decreased costs. And if we quantify that, you can see that for a septic patient, you got a saving of about $11,000 per patient and close to $3,000 per patient in lower respiratory tract infections. And annual savings, $10.7 billion for sepsis and $5.4 billion for lower respiratory tract infections. So when you do the sums, almost a no-brainer here to use PCT guidance in your treatment. So to conclude, we know that the emerging bacterial resistance calls for more efforts to reduce unnecessary prolonged use of antibiotics. And I think in relation to that, two of the important concepts which are discussed today, I think are very valuable and very useful, being rapid diagnostic and use of biomarkers. These are effective, they're evidence-based approaches for antimicrobial stewardship. And yeah, that was my last slide. Thank you.
Can I invite our speakers to sit in front, Prof. Q, Dr. Rule, Dr. Said? Have we got the mics ready? Prof. Shelek's hand is up first. Where's our mics? It's coming. Go.
Thank you. Can you hear me? Is it fine? So maybe if you could just indulge me, I've got a question for everyone. Nenene, with you spoke about the tripartite, internationally, but in South Africa, I think Prof. Naidu also alluded to earlier that we don't, the two departments, and I had a discussion with him in tea time as well, that the Department of Agriculture and the Department of Health doesn't necessarily talk to one another. So as a policy specialist, I'd like to have your opinion on that. And then Roxy, I just wanted to ask, you mentioned that lower respiratory tract infections and bloodstream infections and the abdominal infections are the three conditions, where we see antimicrobial resistance most prevalent. So, do you think that could be a focus area starting our efforts? And then just for Prof. Said, I wanted to ask just what's your opinion from a kinetic point of view on mutant selection windows and mutant prevention concentrations? Because we do need the MIC as well, in terms of when we start treating patients with antibiotics for dosing. And then I just also wanted to ask, I'm sorry, I always wanted to ask these questions now that the PCT, the values have often been found that we're not sure if the break points in terms of the values, if it's not too sensitive. So from a stewardship point of view, the study that you showed, the STOP study that comes from, I think it's the Australian study, where a lot of clinicians said they would like to use a PCT to stop antibiotics, but they don't want it to use it to start antibiotics because they're not completely sure if those breaking points are not too sensitive. And then if I may ask the chair's opinion in pediatrics on PCTs as well. And then I'm sorry, it's just the last thing that I just wanted to ask, how available is the BCID in the public sector? Because I think it's fantastic. And then just in terms of micro, the languaging, sometimes I'm just wondering, like you would talk about the NLF. And a lot of people, clinicians, pharmacists, nurses, I think it's important to teach that terminology, because even if we don't have, and I know we do a BCID, but you can already start treating if you know if it's a non-fermenter, because you can already start, splitting some of your organisms out. So just the languaging, so those were my questions. And my last question is, do we still use an ESR in the hospital? Okay, thank you. There's a lot of questions. Sorry, I apologize for all the questions.
No problem, but maybe you must just keep that close if we forget one. Okay. Prof. Q, do you want to start, please?
Okay. Yes, it's sad to say that even within the veterinary space, there's still some challenges in terms of communication. But I think, although there are these challenges that are existing, we are making progress. As you know, the Ministerial Advisory Committee is a joint effort. But I think the challenge is that there's protectionism going on, that each profession is trying to protect their own end. we need to get to a point where we have one vision. But at this stage, we are not there yet. And I think that's something definitely we have to work on. And I think having meetings like this one, I think you're also aware that we started a One Health program where we get medical students to the Onderstepoort campus. So it's one of those efforts to start at grassroots level, to build up the relationship so that by the time we sit and discuss these issues that we are on the same page.
Roxy?
Thanks, Prof, for your question. I think you are absolutely right. I think if we start focusing on those 3 syndromes first, we already make great strides in combating this issue. I think especially with lower respiratory tract infections, because that's where we see a lot of inappropriate antimicrobial prescriptions happening. It could be a viral infection and antibiotics are given. And I think that then brings in Dr. Saeed's talk as well with the use of these rapid molecular tests that can differentiate if this is truly viral or co-infection or what's actually happening. So I think if we focus there and educate our clinicians in the emergency departments and so on the appropriate use, have guidelines for them to follow and using these other additional PCTs and so on, I think it would be a huge help, definitely.
Okay, thanks. I hope I'm going to follow all your questions, but I'm going to try. Okay, so the first one you asked about the MPC or the mutant prevention concentration. I think that currently, the MIC is still the value that is going to give the greatest clinical benefit. Because as you know from pharmacology, your dosing and all that is based on MIC values. So for invasive infections, your MIC is still going to be the most valuable currently. Yes, we should be testing for mutant prevention concentrations. However, I think when it comes to a diagnostic lab, that is not a standardized methodology to do that. I don't know in the future if that's going to happen, but because we're seeing older, MPC is not a new concept, older concepts coming in like synergy testing now we have to do to see which drugs will work. So maybe, that will come back into the mainstream lab. And that methodology can then be standardized. In terms of the level of the PCT we spoke about, I think a lot of the data that, or what we rely on is based on that SEP study. So the clinicians will look at 80% drop or more in PCT. And that study had showed that if you look at 1 nanogram per mil, or 0.5, I think it was in that study, and it was actually 2 values that they used, that was much more sensitive to show that your infection has now tapered off. And you're quite correct to say that, yes, the efficacy of PCT is to stop antibiotics and not to start antibiotics. It has been proven by multiple studies. With regards to the BCID panel, these panels are available in private, right? There was an issue with regards to funding of those panels with medical aids. However, that has now recently been approved, provided it is done in hospital and is requested by a specialist. With regards to public sector, it's the NHLS is the body that represents laboratories in the public sector. So the process is more complicated in that it has to go sort of towards a national evaluation and tenders, those type of things. So currently what I know is that some of these assays, multiplex panels are being evaluated on a national level. So hopefully we're hoping that we should have it because it's the way to go in the future. There was one more.
Just the languaging, like the NLF and, I was just wondering, when you communicate.
Yeah, look, I think from my side, from our side, what we do is that, and some of the registrars are here, they can bear witness that I always say, when you're saying GNB, what is I know as GNB, but the clinician doesn't know as GNB or GPC. So use the proper terminology. Or you go to the ward, you're saying oxidase positive. We know, but they don't know. So I think it's education. It's just when we do the rounds, I keep on reinforcing these type of things. And I think in the laboratories, our new consultants, and that should also focus on that.
So you've got your own little languaging there. And then just, if I could just ask, sorry, last, Prof. Du Plessis, your opinion, and maybe Prof. Tien's opinion as well. There's a lot of controversy around PCT, especially in neonatology and in pediatrics. And in the private sector, you see them using it a lot. But in the public sector, they don't, because of the developmental systems and where the PCT is from, a natural. So I was just wondering if you use it or not.
No, so I know there's a lot of controversy around PCT and CRP, and I think the main problem, we didn't discuss this in private, is that once a physician in private gets hold of a new test, they seem to almost try it out for themselves. So we see a lot of normal respiratory tract infections in private where the pediatricians would do a CRP and a PCT. And that's really sort of a waste of resource. I was almost going to ask about PCT is fantastic if you can gatekeep it, if you can keep it for specific ICU patients and stopping antibiotics. I think there's a role there. But once you give it to the wider community, they use it quite freely. So in neonatal, I know there was a lot of issues with the value of PCT in the neonatal unit, and we're not using it regularly at the moment. We still look at our trends and our CRP trends, and obviously clinically, I think I've discussed clinical, but you have to look at the patient in front of you and then decide what biomarkers you're going to do. Do you want to?
Yeah.
I just think there's not enough information, especially on premature babies, on what values should you use and how well do they produce all of these factors that lead to the rise of PCT, etc. So we used to do using serial CRPs, especially in the premature babies. I'm not saying in the end there won't be a role, but at this stage there's just not enough for us to move from serial CRPs to PCTs. So while I have a microphone, may I?
Yes.
Okay. I think this is for the blood cultures, the multiplex PCRs are wonderful, I agree. I still have a concern with respiratory panels and the abuse of respiratory panels as we see in the wider community. I mean, we all know that you find all types of things and what to treat and what not to treat, and when you tell a mum a child's got triple pneumonia because there's a BOCA and a rhino and an adenovirus and co-infections, where do you go? So, I mean, my advice is always that people shouldn't be doing these multiplex PCRs until they know how they're going to interpret it. By all means, when you find influenza or RSV significant, if you've got a child with a clinical picture of an adenovirus and you find the adenovirus, but a child with a little bit of a runny nose and a multiplex PCR now, triple pneumonia, and you treat the S-strep pneumo, which is in his throat now. You want to comment?
Yeah, I agree with you. I alluded to some of that earlier, yeah. So I think we need to be selective, and one of the ways I think that can be done is, almost in the wards, you should have algorithms in place as to when you're going to use these tests, especially for the junior people, the interns, and those people coming in. It should almost be, gate kept as well, like your testing. So who requests the test, when you request the test, you should have your algorithms in place. And I agree, I mean, it's very difficult to interpret. At the same time, in terms of when you do have such a situation and it was a valid test requested, the laboratory can help you. We can look at some things like CT or cutoff values, things like that, to help determine which is a true pathogen and which is the colonizer.
Thank you. Yeah, I think it comes down to communication. Yeah.
Exactly, yeah.
All right. I don't know if you got a question, and then we'll go to online. Can we give her a question and then online? Yes. Thank you.
Okay. Thank you. I just, looking at the antibiotic stewardship, it's also important to look at antifungal stewardship. And I just wanted to know if there's a role to play with the PCT test and to diagnosing fungal infections. Can you use it for that, or what do you use as a tool for your fungal infections, your invasive fungal infections?
Okay, so I assume you're talking about invasive candidiasis in particular. Yeah. So PCTs generally do not rise in fungal infections. The reason being because there are different cytokines produced in response to fungal infection as compared to bacterial infections. It does rise to a degree, but most studies show that it doesn't go beyond 1.5 to 2. The more sensitive test that you can use if you're suspecting fungal infection is a biomarker called beta-D-glucan. So that has been shown in certain infections like invasive candidiasis to increase, because beta-D-glucan is a byproduct of cell wall production in fungi. So that can be used, and that can be used to determine if you've got a fungal infection or not.
Okay, so some benefit. Can we have your online questions?
Okay, thank you. So we have a question from Andrea Alero. He's a PhD student from pharmacology right here. His question is, hi, great talks all around. My question is for Dr. Rule, but also for the rest of the panel. With the current trend of pharmaceutical insufficiencies, which is bacterial resistance is emerging faster than effective therapies, what do you think future clinical interventions look like? Will drugs catch up? Or do you think biological modalities such as targeted immunotherapies and CAR-T will take over? Thank you.
Thank you for that question. Yeah, it's quite ominous when you look at that antibiotic pipeline, and I read somewhere that about 1 in 5 drugs that reach clinical trials actually get approved by the FDA. So it's really not a great picture looking forward. But I think we do need to start looking at alternative modalities. So as mentioned, some of the biological agents, if we can target the host response to that infection, as opposed to the organism specifically, that might help. Because we know a lot of the damage that's caused is often due to the host response. Or looking at bacteriophage therapy, for example, where you can combat specific organisms or multiple organisms with bacteriophages. So those are all strategies that we can look at, but very early in research, I think, at this stage. So I don't know what the future is going to hold, how we're going to see, if we're going to see emerging traditional sort of type antibiotics coming out, or if we're going to see more of the bacteriophage and those alternative therapies coming forward. But it'll be interesting to see. But definitely we need something else to, going forward to overcome this problem.
Thank you. Anybody else?
Okay, so I think one of the things that we have not discussed yet is one of the areas in my department. Ethno-veterinary medicine is one of the areas that we work on. I don't know how common it is in human medicine, but in veterinary medicine, farmers for years have been using plants and trees and all sorts of things to treat infections. So we have a division in our department that works specifically on ethno-veterinary medicine. And one of the studies that we've been doing now is looking at different plants for treatment of multi-drug resistant pathogen, including methicillin and other pathogens. So it's one of the areas that we are definitely looking at and the direction that we're trying to take it.
Yeah, absolutely. Yeah. Thank you.
Sorry, I just have one question for Dr. Said and Dr. Rule. As Prof. Kok had presented earlier, that we're finding that there are a lot of high-risk clones within our hospital settings. So just wondering whether information that is generated from such studies is actually being used in the hospitals to inform control strategies to prevent the spread of these clones in the hospitals.
So we're in the process of generating antibiograms for our clinicians now, so it won't be specific to the types of clones, but we are going to start looking at, what our antibiotic profiles are looking like, and that will be able to then better advise clinicians in terms of empiric therapy and so on when they're faced with a specific syndrome or patient from a certain area. So going forward, yes, anecdotally we are informing based on what we see, but we don't have the official rates of each organism at this stage. That's in the pipeline for this year.
Yeah, my other comment is coming back to what Prof. Shalek was saying. It's that, we're going to be speaking a different language there when we're going talking about ST clones and those type of things to the clinicians. And also, I think what we need to do is we must have more prospective data as well with this, because a lot of the data with the clones in it is retrospective, historical type of data. So how that will translate clinically is also, we're not sure, but yeah, so it doesn't really get discussed.
All right, thank you. While we wait for one or two more hands, Prof. Q, can I ask a question? I was listening to your One Health approach, and I think we've gone a few hours without discussing monkeypox and any new outbreaks, and also no climate change. I was waiting for that. So is there, within this policy framework or in this strategic framework, is there an arm that looks at these new outbreaks and climate change? I mean, just looking at the disaster in KwaZulu-Natal at the moment and the consequence of infection and resistance, even amongst the animals, is there sort of a framework for looking at that within our policies?
Yes, currently the part of the Ministerial Advisory Committee's mandate is to look at the current trends and the future. And one of the flagship projects was the issue of the development of tests, specifically looking at wastewater as a marker for COVID. And so they're trying to find different ways of trying to predict potentially what the future will look like and to try to be ahead of outbreaks if we can. I think one of the things that I think Prof. Naidu alluded to that is that there is another project that is going on looking at abattoir waste as a potential area for future outbreaks because waste from the abattoirs normally ends up in places that it shouldn't. So those are the kind of things that we are looking at to see how best to address those issues. But we also have two colleagues. I remember the other one is from Department of Environmental, working on global and climate change and potentially the development of new resistance. The argument there is that either more plants are going to become susceptible, or because we use a lot of pesticides and a lot of chemicals in food production and the impact of that on the environment and development of new resistance as we move towards dealing with climate change will become a bigger issue that we'll have to look at. So one of the colleagues in the committee is dealing specifically with climate change and development of resistance.
So I was in a meeting yesterday where they discussed polio eradication. And the lady that discussed it says she's sitting and looking outside where sewage is running past a baby clinic. And I mean, how can we discuss polio eradication if that is what they are looking at? So it is a problem, yeah. Any more questions? All right, then maybe I can ask I've also got a list. Not as extensive as Natalie's, but also a list. Dr. Rule, so we discussed antimicrobial resistance. How do you sort of see, how does that fit in with IPC? Because I think with this patient, that the illustration of the patient that was a CRE carrier, how do you see going forward your role in IPC? Do you write it in your reports? Do you phone the doctor? Do you phone the IPC nurse? How do you think we can make this work?
So I do think communication is key. So the current practice in our laboratory is that when we pick up an isolate that is resistant, we do communicate it. So it gets emailed to the IPC team, and we communicate it to usually the doctor that submitted that specific sample. I think that obviously should continue on. I think we should follow up those patients regularly as well to find out, what's happening with them. Were they able to actually isolate that patient? Because we know there's issues with isolation facilities in hospitals as well. So in that case, we could also facilitate, guiding other ways if they don't have a specific isolation cubicle for that patient. You know, we can advise on contact precautions, putting that patient in a corner of the ward and just optimizing, you know, where we can. So I think certainly communication is really key. We should be generating, and we are going to be generating, antibiograms as well, which will better, you know, give the clinicians a picture of what's actually happening in our settings, which units are problematic, and, you know, if we can look at syndromes as well, that sort of thing. So I think all of that could play a role. And then just, yeah, featuring on IPC committees and so on, just to reinforce and educate clinicians as well would help.
Okay, good. Thank you. And Dr. Saeed, I'm always interested in rapid and new technologies. How do you think this will change our gold standard? Because we all go back to the gold standard, isn't it? This used to be culture or something. How do you think this will change? Do you see that there might be a discrepant sort of protocols for ICU critically ill patients where we can use this in general wards, or where do you think this can go?
So, I mean, look, it's, these molecular tests, as they develop more and more, you know, I think they have the potential to completely make culture obsolete, right? So as time goes on, and we are working on some that even give MICs, but the issue comes in with regards to costs. So not only is the initial setup of the PCRs expensive, but the reagents and expertise around that also comes at a price. So there definitely be, it comes back to what I was talking about earlier with algorithms again in the hospital. So we need to now, in the wards, decide that, look, we're only going to use this for ICU critically ill patients, or we're going to use this for oncology ward, transplant units. These are some of the areas where you want rapid, quick answers. So I think that is the way currently to move if we have this technology.
Absolutely, yeah. All right. Yeah, so I think it's interesting, and there are definitions as clinicians also need to change, like what is infection, what is disease with these new gold standards, you know, to really sort of target therapy appropriately, yeah. All right, any last questions? No? Yes? No. All right, so Prof. Shelek has kindly reminded all of us to sign the CPD register for continued education during lunch, please. So it remains for me to thank the three speakers. Thank you so much for a very informative and interactive session. And you are all welcome to go and enjoy lunch up until 20 to 2.
Good afternoon. Welcome to the graveyard shift. I know after lunch, they say we just fall asleep on our chair. So I will be taking over the graveyard shift. So we have 3 speakers coming. Let me see, yes, it's 3, 4. Okay, yes, 4. 4 speakers coming. Without wasting any time, let me call upon Professor Avenant. He's the head of department for pediatrics at Calafon Provincial Hospital. And he is a registered specialist in pediatric infectious diseases. And he has indicated to me that's where I should stop. So I shall stop here. Prof, over to you.
Thank you, Prof. Okay, welcome after lunch then. I think the first thing is that we've all now seen what a big problem antimicrobial resistance poses to global health. And we can see how many deaths are attributable to multi-resistant infections. When we look at the ethics, we're going to look at quite a few aspects of ethics, but the scale you see there will be there the whole time in your mind. So it's always the consequences of the acquired resistance versus the benefit of the antibiotic treatment. So antibiotic use will automatically increase the resistance that there is. And this whole thing is analogous to a collective action problem called the tragedy of the commons. Now, this was described in 1968 by Harden, and it was initially made applicable to economic things. But if you look at this, now this is a common area outside a town or a castle where people were allowed to have a sheep or whatever graze. And that went well until one or two of these people started to abuse this privilege. And then the land was used beyond its carrying capacity. And what it then says, unless we start looking at environmental factors, this common land or common area that we have, in the end will become useless. And it will be unable to support whatever we're trying to do. So this is a very simple model. If you now go and make this applicable to antibiotic or antimicrobial stewardship or antibiotic resistance, it doesn't fit this whole model perfectly. There are a few big differences. The first one is that if a certain individual keep on utilizing more and more antibiotics, he will not have progressive benefits. The maximal benefit is only to individuals who have got targeted therapy, and there are some other uncertainties that complicate this. There are also, if you start escalate your use, the benefits are not getting that much more, but your side effects remain fixed. So your ratio of benefit to side effects become lower and lower. We should also think it's not only the antibiotic use that drives this, but also other things that can contribute to antibiotic resistance or the spread thereof, meaning hand washing, other IPC practices. And then the other last difference between Harden's model and what we're talking about is that the harms of a resistant infection is not there equally for everyone. The harms are very often more located in those ones who have used antibiotics before. So all of this will, again, come down to a conflict of interest. On the one side, we've got the patient and the individual, the immediate needs of a patient. So what does he need now? He's going to die if we don't treat his, or he may die if we don't treat his infection. On the other side, there's the community. So what are we concerned about? We're concerned about the antibiotics not being able to be effective in so many years' time or in so many months' time. And the problem with this is that, and we see the same with vaccine hesitancy, is that the problems of a patient are immediate. And it's always much easier to give your attention or to give more importance to what is immediate rather than things that may happen in a year's time or 2 years' time or 3 years' time. I added a little block at the bottom there and said, you've got the patient, you've got the community, and then there are areas that we use antibiotics that's actually of no benefit, and that's coming back to your question of this morning. So just antibiotic abuse because you don't know what you're doing. Two, there might be benefit to the prescriber that may be just keeping your patients in your practice because you're the only one that is willing to prescribe the antibiotics and your colleagues are not. It may be driven by external factors like pharmaceutical companies or representatives. And then in certain cases, if you don't give antibiotics or you undertreat your patients, you may get some censure because of that. So in the end, who decides on what we do? So this, who will steward the stewards? This actually comes from a Roman poet, philosopher, Juvenal, and the original one said, who will guard the guards? And this is taken a little bit out of context because it was regarding some other issues, but this is now used to say who will steward the stewards. So antibiotic stewards need to be neutral. The problem is that sometimes when, as we on the Antimicrobial Stewardship Committee, need to criticize our colleagues. And that may stop us of recommending actually optimal plans. Also, if you think of antimicrobial stewardship, the resources are concentrated in hospitals, and a lot of the abuse of antibiotics also happen in the community, not only by practitioners, but also in all different other ways. If we start now thinking we're going to discuss this patient and decide on antibiotics, we're going to discuss that patient and we're going to decide on antibiotics and that one, this is labor intensive and may actually not be useful. So we need to think of a much broader way of addressing this, and we also need to think of some of the factors that Roxy addressed as regards to other factors that may prohibit the spread of resistant organisms. So for the next few slides, I'm just going to focus on antimicrobial stewardship in hospitals because that's where most of us are currently. So individual doctors will make a decision on which antibiotic, for how long, do we need to use more than one antibiotic, etc. But then the antimicrobial stewardship committee will have certain policies that we've agreed upon previously. And together, these people must champion the collective good over the individual rights. So the final decision is always a trade-off between treating a sick patient with the immediate effects, and you can actually witness the results of your treatment, versus the long-term benefit for your hospital, where you cannot necessarily see the immediate benefits as you make these decisions on antibiotic use. So how far should a committee insist on adhesion to agreed guidelines? So is it appropriate to ban certain things, especially if you're going to use less effective antibiotics? If you're going to mandate things, make it compulsory, you run the risk of actually alienating the prescribers and losing the whole advantage of your stewardship program. In some cases, you cannot just use general guidelines. I mean, some patients are just different. They've got different inherent factors like immune deficiencies, etc. And the antibiotic susceptibility profile might just be completely high. And often we run into institutional factors, and I mean, this is something that I've run into. You've got an ongoing outbreak or a threat of one, and then I cannot wait for the culture's results before I prescribe colistin. I need to go now because these are premature babies. So some of these things make it very difficult to be extremely prescriptive in what you are doing. So guidance should actually be advisory rather than mandatory. And as we discussed this morning, when there are guidelines that tell you you may or you may not, it's easier for you as an individual physician, especially if you're a junior physician, to say, no, the guidelines say I'm not going to prescribe meropenem as my second-line antibiotics. I'm going to prescribe tazocin, or we need to wait. And it becomes easier if there are guidelines for senior people guiding you. Wait and see. Many instances you can use a wait and see policy. There will be exceptions like very premature babies where the sepsis can actually rapidly progress, where you will treat rather than wait and see. We spoke about legal challenges this morning. So if you refuse now to give somebody what is regarded as optimal individual treatment, you may get legal challenges. And then you may also run into a situation more at the, maybe a committee or even a wider thing, where when certain economic factors start taking over the decisions, what's the cost of the antibiotics, blah, 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 and then suddenly they're driven by different factors. I thought of just including a slide on managers. And this has been one of my pet topics in a sense of when we talk about IPC and when we talk about antimicrobial stewardship. For people who want to establish these type of programs, unless hospital management is on board, jy kan op jou kop staan en jou tone wikkel. I mean, you can try whatever you do. Unless the managers are involved, you're not going to be successful. So hospital managers actually report when they want to do these things that there are considerable difficulties. I think there's a perceived culture of that doctors do not actually use antibiotics properly and they don't know what they're doing. So that's one of the perceptions. I think the important thing is also to look that sometimes you get non-clinical people that want to make decisions on your antibiotic use. and the way you manage your patients. That's unethical. So you cannot have non-clinical people decide for you what you need to do with your patients. So managers should be committed to controlling it, and I think there should be really good communication and relationships between managers and doctors to make this work. Okay, now coming back to a bit more hardcore ethics. In undergraduate medical school, we all are taught the medical ethical framework of Childress and Beauchamp. Now, Christina Yen and James Cuttrell went and they, as regards to antibiotic stewardship, put this into 3 categories, and we're going to look at each of them in all the categories. The first would be the individual, which may be the doctor or the patient, then the institution, in our case mostly the hospitals, and then broader society. So the first one we're going to address would be autonomy, and I think that is one where most doctors feel most threatened. I mean, are your antimicrobial stewardship policies encroaching upon the prescriber's right to initiate or change or do things with antibiotics? Can the patient make an informed decision on all the possible aspects of this decision that you've made? If you then go look at the autonomy in more hospital contexts, so if we think of pre-authorization, is this limiting the choice of the doctor or of a patient? And what should a hospital do now if we find that Prof. Du Plessis is all the time the outlier and she's prescribing the wrong antibiotics? What can we do, and are we encroaching on her autonomy? And can we actually then in society restrict the use, and how does this limit the interests of a group? The second principle then would be justice. That would be balancing the benefits to patients and society with equity and impartiality. So what do you decide? Is this favoring a certain individual or a certain group of individuals now? Does it limit the access to a certain group of patients if you start these things? If you look at the hospital, how does this impact the institution if you start limiting antibiotic use in certain areas? Let's say we decide we're just going to do this in this ICU or in that surgical ICU or whatever. So how does this impact? And whatever we measure in the end, is it appropriately measured? So in society, we need to ask whether the intervention, again, favor a particular individual, and what's the total cost or the opportunity cost if resources are used. So can we use it for other things? Non-maleficence then would be do no harm, or avoiding or minimizing harm. And I think that's also a great concern when you get to the ethics of antimicrobial stewardship. So does the intervention actually reduce patient or prescriber harm? That's not always. How does the intervention expose the prescriber or the patient to harm? I'm not going to read through the non-maleficence in the hospital through all of it, but I think important here, if we start implementing antibiotic stewardship, are we always telling the truth? Are we hiding the truth somehow to say, this is why we're starting a certain group of antibiotics or withholding, and then it may not be the whole truth. And certain stakeholders in society put at higher risk than others. I mean, let's think of, you've got a big group of immune-compromised patients in the society. Are your actions going to harm this group? Let's not say we say no antibiotics in the bigger society, and there's a group of people who need prophylactic INH or Bactrim. Are these stakeholders going to be harmed? Beneficence, how are we going to help? So will it help the individual patients if we now limit the access to antibiotics or shorten the course of antibiotics? And I think it was actually your slide, Mohammed, that showed that patients are actually benefited sometimes if we do proper antimicrobial stewardship and we start antibiotics earlier. On the last column there, beneficence to the society. And I think this is the major argument. And what immediate or future benefits could this intervention that you're doing have on individual patients or hospital or society at large? And I think this is where antimicrobial stewardship has its biggest benefit. Then we shortly just need to touch on distributive justice, and I think Prof. Q has already mentioned some of the distributive justice things in his talk. So, restriction of antibiotics can be justified on the grounds of distributive justice because of the future, but it's very unlikely that we'll stop antimicrobial resistance with this alone. We also need to think of the other things that you've mentioned, new antibiotics, development of better communication strategies, other ways how we communicate this. So in the end, if we ration antibiotics, it's very unlikely that in the end we'll be able to stop antimicrobial resistance totally. It's not going to happen. And we need to make sure that we're not going to meet with public disapproval. So look at other things. But I think at the bottom there, a lot of people mentioned this like on the sides. We need to learn to live with bacteria and viruses and whatever. We for so many years, I mean, for all of the years of mankind, we've lived with bacteria. So we need other ways of living with bacteria and think of other strategies like you've again mentioned. Most of the people that, well, there are many more people that die because they don't have access to antibiotics than they die of antimicrobial resistant organisms. No. And also, if you know, there was a good slide in one of the previous talks on how the resistant organisms actually are affects middle and lower income countries much more. And when you've got a weak healthcare system and you need to deal with this, it's very unlikely that they'll. So this whole thing of limiting antibiotics, be very strict, may advantage more wealthy countries at the expense of poorer countries. So whenever we, on a global scale, start to initiate things to stop antimicrobial resistance, there need to be assistance to these countries who will not be able to do these things on their own. On the chart, you have an idea of the spending on healthcare in countries. Okay, so the next question now, especially in a country like ours, we very often speak about rationing of. If you now start thinking about things like dialysis, that's not available for everyone, or an ICU bed that's not available for everyone. So we're quite used to it. So is antimicrobial stewardship a form of bedside rationing? So Ubel and Gould actually devised the definition of bedside rationing. The first thing is that clinicians must withhold, withdraw, or fail to recommend a service that's actually in the patient's best interest. 2 is they must primarily do so to promote the interest of someone other than the individual patient or than the bigger society. And in the end, this specific individual must have control over what's happening, because then it's rationing. If he has no control, it's not rationing. So now, is it justifiable to ration things? And Normal Daniels actually had an approach called accountability for reasonableness, or AFR, and to legitimately and fairly make a process that we can use. And the requirements for this AFR is fourfold. The first is that whatever you decide now to do, rationing, must be public. So it must be there for everyone to know why you've made these decisions. It shouldn't be something that is secret. Secondly, it must be relevant. It must be things that you can justify and that actually makes some sense and most people can agree on. And then if you think of antimicrobial stewardship, whatever, there must be a way where people can say, I don't agree with you as an antimicrobial stewardship committee. We want to appeal this decision, or we want to say, why should this be done in this way? And the last one is enforcement conditions. So there need to be a regulatory place where you can make sure that these conditions are met. Okay, so antimicrobial stewardship actually fulfills all of these criteria. And if you look at the growing success of antimicrobial stewardship programs throughout the world, it is clear that they're actually successful in doing a lot of good. So in the short term, antimicrobial stewardship programs may compromise some individuals' health, but in the end, the critical ill population in general will benefit from antimicrobial stewardship. I'm going to say, I've got 2 slides for veterinary antibiotics, but I feel completely out of my depth, so please comment should you need to. If you think of the ethical use of veterinary antibiotics, Prof. Naidu told us that in South Africa it's about a quarter of the use for the animal use. No. But we need to think that animals have rights too. There are ethics that regards animals too. So we cannot just now say, we're not going to, I see somebody jumping up and down there because when I said animals have rights too. I mean, we cannot now stop all antibiotic use in our pets, in our livestock, etc., because we're concerned about humans. It will not. We need to, in the end, balance again what's happening in animal health and what's happening in human health. And yes, antibiotics are there to promote growth and to increase production of food. And in many countries, it will be impossible to actually produce enough food or enough cheap food if you don't use antibiotics. And one will need to somehow see how you're going to compensate. It's not as easy as discussion as we've told. We've heard about new biobubbles, and all of these things, but all of them are costly. And if you think of the areas where these things are used, they may not have the money. We had quite a detailed discussion about colistin, and I think colistin for us is like a last resort antibiotics. So if we just use entire classes of antibiotics for humans, the veterinary people will have problems. Now, we can't not allow them to use or see that they can use that. So we also need to think, if we now say we're not going to allow metaphylactic use, that's treating the whole herd and just need to go and treat the ill animals. What you mentioned, 130,000. Do you need to test everyone? Do you need to now treat only the sick animals? How are you going to isolate them? It becomes impossible. Now, so we also need to think of practical issues, but I'm sure the people from Honest Report will comment on that. So, in conclusion, biologic antimicrobials are ultimately doomed to fail. I mean, we're using it for a short part of human existence, and that will in the end come to an end. But we can stall antimicrobial resistance by using the correct stewardship policies. Ethical behavior encompasses actions that benefit both yourself or the individual and society. And tackling antimicrobial resistance is an ethical obligation for all of us. We cannot not give attention to it because the prospect of declining anti-infectives affect everyone. While we are free to choose our actions, we are not free to choose the consequences of our actions. Thank you.
Thank you very much, Prof. You are right on time. I had an extra 5 minutes for you, but thank you very much. You're right on time. Let me call upon our second speaker, Dr. Karabo Mohali. She is an emergency medicine registrar at the Steve Biko Academic Hospital. And she is currently pursuing a MED vet research focused on competency and knowledge of junior doctors regarding electrocardiogram under the supervision of two esteemed colleagues. She is dedicated and enthusiastic about teaching and learning in emergency medicine. Doctor, over to you.
Thank you. Yes, I was saying that I'm grateful for the opportunity, and I'm actually planning when I go back to the department to re-emphasize on certain principles that have been touched on. Before I get to the things that I was planning to touch on, looking at my experience in the appropriate use of antimicrobials, I just wanted to touch on what my colleagues from microbiology have emphasized on. I think the new generation of diagnostics, basically the PCR diagnostic tests, they will make a huge difference, especially in the emergency setting, because my personal experience is that often in the emergency department, it feels like we are shooting in the dark most of the time. Especially you find that we have sick patients that are coming in. In Steve Biko Academic Hospitals, a lot of our patients have been exposed to antimicrobials, maybe at primary level of care, also at secondary level of care. We know that the guidelines say that early use of antibiotics is, it improves outcome. However, inappropriate use of antimicrobials as well is also detrimental. So our challenge in the emergency department is that we do follow local guidelines, we do draw specimens, we do send swabs across, but by the time the results come out, the patient has been disposed to their appropriate level of care, be it high care, ICU, or in the wards. So when Dr. Rue from microbiology calls me to say, patient XYZ has cultured this, and then this is what it's sensitive to, obviously, number one, in the emergency department, we do remember our patients by name. It becomes a challenge, because then you have to kind of think who is the specialist doctor you refer the patient to, try to get hold of them and be like, this patient has cultured this, and then we just hope that the patients in the wards, obviously the physicians and then the specialist doctors will be following up the investigations that we've started in the emergency department. Also, I wanted to touch on the use of procalcitonin. We do apply it, especially in the COVID setting. Pre-COVID-19, our patients coming with community-acquired pneumonia, their management was quite straightforward. So we would score them depending how sick they are. They warrant for outpatient or inpatient management, and then we start the antimicrobials according to local protocols, await specimens, and then change the treatment according to the results we get from microbiology. However, now with COVID-19, our patients that are moderate to severe pneumonias, we know for sure that concurrent bacterial infection in COVID pneumonia, it's very unlikely. Prof has highlighted that it's less than 10%. However, our PCRs, like I have said, the 10-out time would be something like 6 to 12 or even 24 hours. And then our rapid test is highly specific but not very sensitive. So in your PCR negative patients that are coming in with pneumonia requiring some form of supplementary oxygen or some form of ventilation, then we still have this dilemma. Is it really COVID pneumonia? The rapid is negative. Or is it likely to be a bacterial kind of infection? We do send our procalcitonin across, but then the turnout time would be 8 hours or so. But our colleagues from internal medicine and from ICU, they have the privilege of reviewing the results and then stopping the antibiotic. Another bedside modality that we use in COVID pneumonia, it's our bedside ultrasound. So in patients like the previous case that I've said, they have rapid negative, and then we think it's COVID pneumonia. We don't want to start antibiotics because we know these patients do well on other therapies which have been proven to work in COVID-19, and that they don't warrant to get antibiotic use. So in these kind of patients, we can use bedside ultrasound where we look for features that are specific to COVID-19 pneumonia. And in these patients, we know for sure, although the rapid was negative, we're still waiting for the PCR. I am not going to prescribe Augmentin. I'm not going to prescribe azithromycin, for instance, because I know from the ultrasound features that this patient is likely to be having COVID pneumonia. I had a chat with my colleagues who have had the privilege of rotating in COVID high care and COVID ICU, and they're saying regardless of the local protocols that we are having, the use of bedside investigations, they still get patients who have COVID pneumonia and still are put on antibiotic use. So I think with these, if then we can have a rapid turnaround time of our investigations, this will assist us in the stewardship of appropriate antimicrobial use. Is just something I wanted to touch on. As we all know, our healthcare system is divided into primary, secondary, and tertiary healthcare. And then I've had the privilege of getting exposure from all the 3 levels. The previous speakers have mentioned that protocols and algorithms are quite useful, especially in a setting where, where we have junior colleagues or medical officers, etc., where if a patient comes in, then you know when to prescribe antibiotics, when not to prescribe antibiotics, and what investigations to use. For example, in primary healthcare, I use the EML guidelines quite a lot. Also in secondary level of care, the EML guidelines is the essential medicine list, which was published by the National Department of Health. So it says, for example, a patient coming in with UTI, in addition to sending your sample to the lab for urine MCNS, you will start them on an appropriate antibiotic according to the local protocol. And then in the EML guideline, they would suggest either nitrofurantoin or ciprofloxacin. You follow up the patient in the next couple of days, and then you adjust the treatment according to the results. Okay. Also for secondary level of care, it's basically the same concept. Currently, we are at a tertiary level of care. However, what I've realized from my personal experience is that the principle is the same. It's to know when to use the antimicrobials, and then to send the appropriate investigations, adjust the therapy according to the results that you have found. The privilege of being in a tertiary setting is that the patients, although it's patients that are severely ill, needing tertiary level of care, however, there's a multidisciplinary team approach. So it's unlikely that I have to make decisions on my own for the care of the patient. For example, patients that come in with neutropenic sepsis, we see patients like this in the emergency department. Our patients on chemotherapy, we know these patients are severely immunocompromised. When they present to the emergency department, we treat them in conjunction with the medical oncologist on call, and then they advise on the appropriate use of antimicrobial therapies depending on the presentation of the patient. The challenges I've already mentioned, the one of the loss to follow up, where we're getting patients that are severely sick, and then we have to kind of start what we can start and then see what the results are going to be. But by the time the results come out, the patient has already been disposed. Another challenge with loss to follow up will be our patients that we down refer to local facilities. With Tshwane District Hospital closing down to become a COVID hospital, we have seen a lot of these primary healthcare and secondary healthcare patients where there's no indication for admission. However, there's a need for follow-up. So you will send across your specimen for urine MCNS, for example, but you're not sure if your patient will go to their local district hospital to get the results reviewed, or if they're just going to think, no, the treatment they gave me at Steve Biko didn't work, so I'm just going to go to another GP, for example. And then our patients, they also don't understand the level of care that they need to start at their clinics. So you find patients who start at their primary level of care, and then they don't bring what has been already started. If it's a patient that comes from the clinic, for example, I know the clinics use the EML guidelines. I know if it's a patient coming in, for example, with vaginal discharge syndrome, I know the treatment that this patient has gotten at the clinic based on the EML guidelines. And if this patient is saying, but the treatment didn't work for me, then I know this patient probably needs to be discussed with the gynae on call, for example. However, if it's a patient that's coming from the GP, we don't know what antimicrobials they've been exposed to. Some patients don't even disclose that they've been treated at a primary level of care. So when they come in, you kind of don't know where you're standing. I always try to explain to them, you must tell me what you've taken, because what if then I'm giving you the same treatment that is not working for you? And then I've mentioned the diagnostic challenges with COVID-19. Yeah, and then so basically our patient population are lacking that information. Okay. So our way forward, obviously I'm not a public health specialist, but I think if we get assistance from public health to educate our community, and then inclusion of all teams involved in patient care. I get grateful when the pharmacist calls and they're like, doc, you've prescribed this. Are you sure about the dosage? This patient has already been on this. So that also assists in the stewardship of antimicrobials. For us in the tertiary level of care, specifically in our department, I think that we need to put in place proper algorithms. For example, if a patient gets cardiac arrest, I know the algorithm that I need to follow. So I feel like even with antimicrobial therapy, being that it's such a critical concept, if then we get proper guidelines to follow, like for each symptoms that the patient would be coming in, for example. Yeah, and then I've mentioned the other aspects, that the turnover time of lab results from microbiology. And yeah, so that's what I had to say. Thank you.
Thank you very much. Thank you. You can just leave it there. Thank you. Thank you very much. Again, my speakers are on time. I'm doing a great job. Thank you very much. So let's call our third speaker for the day. I don't know if I pronounced it right. Tian. Yes, it's Tian. Yeah. Tiane, yes. So Tiane is a community pharmacist at Calafon Tertiary Hospital. A lot of Calafon people here. Calafon Tertiary. Yeah. As a pharmacist, her main focus there is ensuring optimal patient treatment outcomes as a pharmacist, and she's passionate about antimicrobial stewardship, and she's currently pursuing her master's in pharmacology with the focus on antimicrobial stewardship. So over to you. The thing is over there. All right.
Okay, good afternoon, everyone. It's such a privilege to be here. Thank you so much for inviting me. And basically, I'm just going to stand here and talk to you about a pharmacist and their role in antimicrobial stewardship. So based on my outline, you will see I will just have a quick introduction, what AMS is about, especially regarding pharmacy, what our race is against resistance, my job, improvements that I've seen in stewardship, and the challenges that we still face, as you've heard that I work in a state hospital. So, even though I just told you I am a pharmacist, I'm here to sell you a car. Someone told you that you need a car, so here I am to sell you a car. This one is brilliant. You'll see its gas mileage is just impeccable. It can take you from point A to B just as you need it. And I mean, that's the reason why you came here today, is because someone told you you need a car. And so throughout my times, I have been giving these cars out. And so I can give you this car today right now. And we can just figure out the financing and if you actually do qualify for this car. Is this actually the car for you? Later on. I do have to warn you, though, that if I sell you this car and you don't really qualify for it, the gas mileage kind of drops off a bit. And the manufacturers has even been warning us that if this car doesn't qualify for your needs, at some point it might stop working. So now, one small minor thing is if you drive away with this car and you later decide that maybe this isn't the car for me, there might be some serious issues for you to buy your next car. So as ridiculous, oh, but you're still interested, right? You're still interested in the car, right? So unfortunately, as ridiculous as this situation sounds, it's a lot akin to what's happening in our healthcare system, especially when it comes to antimicrobial stewardship. So we really have to take a step back and ask ourselves, like, are we the problem? People coming in being told that they need an antibiotic. And we as car salespersons know that this might not be the right car for them. So according to stats in 2020 to 2021 in America, it said that 90% of general practitioners felt pressurized to prescribe an antibiotic, where 70% of them were unsure what they were treating. Was there even an infection? 50% of them prescribed something without knowing if it's medically necessary. There was an article published in March 2019 by the University of Witwatersrand where it says that about 76% of patients that walked into the public sector and 67% of patients going to private GPs got medicine even though there were no symptoms of them having an infection. So most likely in South Africa at this point, 2 out of every 3 patients that walk into a doctor's office leave with a script with antibiotics on it. So, unnecessary prescribing is not without consequences. We all know this. We all know that antimicrobial stewardship is a problem. So we know by now that the more we expose these bacteria to antibiotics and we don't appropriately kill them, they become accustomed, evolve, and they become resistant. So more and more of this enteric bacteria are being reported as being drug resistant, especially in the USA, where antibiotic resistance is now the reason and accountable for more than 2 million people being hospitalized, leading up to 23,000 deaths annually, costing the US hospitals almost about $20 billion in excess health care. I don't know about you and what you believe in South Africa finances, but we don't have $20 billion in excess money to pay for these excess costs. We do have money for flags, though. So maybe this is the next step. All right. So a lot of people, especially when I was starting to speak to my colleagues in preparation of this presentation, a lot of them were like, superbugs is it's a modern problem, right? This just came in 2020 to 2010, it's something new, where in fact, Alexander Fleming called this phenomenon 77 years ago. He knew, as you can see here, these microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out. In such cases, the thoughtlessness person playing with penicillin is morally responsible for the death of the man who finally succumbs to the infection of the penicillin-resistant organism. I hope this evil can be averted. So this is our role as healthcare professionals, is to go and be this difference that Alexander Fleming asked us to be, to go and help divert this evil. Because by now, antimicrobial resistance isn't going to be stopped. It can be slowed down, but resistance is already there. So it's up to us now to make sure that we can physically work and culture and steward this so it doesn't lead to us not having antibiotics in the next 10 years to use anymore. So, but we will have new treatments, right? So no new treatments, no problems. Big Pharma is going to step in. They're just going to throw out left, right, and center antibiotics for us to use. We shouldn't stress, right? I mean, in Barack Obama had a 10 by 20 initiative that he asked that there should be 20 or 10 new antimicrobials by the year 2020. Do you think that we are on track? Definitely not. So, also please keep in mind that when it comes to antimicrobials, antimicrobials do not make money. If you have to compare a medication being made for blood pressure and diabetics, something that you chronically use every day, versus antibiotics that are short-coursed, maybe a month long if it's a bone infection, that doesn't scream money. That does, and obviously, as much as we would love to take care of patients, money ultimately does make the world go round. So here you can see these from 2010 to 2015 are the antibiotics that have been approved. If you'll see it, there's CA and CT at the bottom, which is very exciting. We are currently writing an article on how to steward and introduce these two antibiotics. So that article is coming soon. And so like I said, we are definitely not on course when it comes to bringing out these new 10 antibiotics. So ladies and gentlemen, we are at a crossroad. On the left side, we can hope and pray that more antibiotics get devolved and get approved quicker by the FDA. Or on the other side, we as healthcare professionals should start and take matters into our own hands. And by doing that, we can start applying antimicrobial stewardship to make sure that these antibiotics are still available for generations to come. So we know the AMS building blocks. The things that we need is the right drug, the right bug, dose, route, and duration. By this, the aims of antibiotic dosings are to maximize the rate and extent of bacterial kill, minimize the development of antibiotic resistance, and to minimize the possibility of drug toxicity. All of this enhances the likelihood of positive clinical outcomes, which of course is our primary outcome. So, now I'm back to being a car salesperson. Don't you just love how I can switch professions like this? So, do you really need a car when the patient comes in? Does this patient really need an antibiotic? Second of all, does this car fit the need of the antibiotic, of the patient? Are we giving the wrong antibiotics? Did we actually take culture checks and check for specificity? And lastly, does this car have too much power? Is the dose that we are giving the patients too high? Was there some blood works checked to see what the functions of the liver and the kidneys are? Back as a pharmacist now. Pharmacists have a critical role to play in helping stop the spread of antimicrobial resistance by dispensing antibiotics in a safe and rational manner, and also spreading awareness about the dangers of inappropriate use. So pharmacists have the responsibility to assist in the war of this antibiotic resistance. We have the knowledge and we have the resources at our fingertips. And as we are the last professionals who sign off on scripts, it is a daily reminder how we are custodians of medication and that we can actively play a role in whether we are slowing down resistance or are we playing an active part in creating an even bigger epidemic in this race against resistance. So just a bit of my experience in antimicrobial stewardship, going from university to shadowing to now working full-time. If I have to be full disclosure, in university, we didn't get taught a lot about antimicrobial stewardship. I think Prof. Sheila can testify they did a study on 4th years and what their response is to antimicrobial stewardship and what they understand regarding it. I think my antimicrobial lesson was 45 minutes long, and that's that. All I know that is it's wrong not to look after antibiotics. And that was what I was taught. So there was no antimicrobial stewardship champion laid out foundation for me. So my real life started for the importance of antimicrobial stewardship while shadowing clinical pharmacists in Netcare and Life, and I even had the privilege of shadowing a clinical pharmacist in Privita Hospital in Dubai. And just standing there, watching these healthcare professionals, not just the pharmacists, but healthcare professionals in general coming together, studying blood cultures, tailor-making things for patients specifically, it just sparked something in me. And that's where passion starts. And that's where we realized that patients deserve to have a tailor-made antimicrobial chart for them, microbials for them. And I just knew that I wanted to be a pharmacist like that. Someone who had the patient's best interest at heart, but also how to use medication wisely so that these miracle drugs can still be used for generations to come. So now antimicrobial stewardship in the public sector where I currently work. So I have been doing my internship and my community service in the same hospital. And in South Africa, we know that 82.5 to 84% of South Africans use public healthcare as a primary service. Scary enough, only 37% of pharmacists practice in public health. So most of the public sectors where I work, including Kalafong, we would know, is paper-based. And that can lead to a lot of missing gaps. So being placed for internship and community service throughout the same hospital certainly had its perks. I went from in my internship to seeing how we basically write if the doctor prescribed amoxicillin. We write down in this thick book, amoxicillin. We gave 10 of them. It was worth 15. And that was our idea of stewardship. Nice. We wrote something down. Good for us. And now Kalafong actually has an antimicrobial prescription chart. And we just had this discussion with Prof. Tians, where it regularly gets sent back now at this point because the form is in such excellence that now the doctors have to give the specific indication of why you are prescribing your antibiotic. There's blood cultures needed. You as the prescribing doctor have to sign, and the ward supervisor has to sign. So by the time that script lands on my table, 2 healthcare professionals has looked at it, and now 3, me, will be looking at it. So as 3 heads are always better than 1. So I can personally say that has made a massive difference in the way that we are busy stewarding our medication in Kalafong. One thing that is my time done? Let me just say how many. We have challenges in state. Yes. Fine. Thank you.
Thank you very much. So as we prepare for our last speaker, the previous speakers, if you could have a chair here, so that when we do our last session, that everybody is very close. So let me welcome Sister Miriam. Did I say it right? Correct. So Sister is at a critical care clinical facilitator at the Steve Biko Academic Hospital. If you don't know where it is, next door. And she's responsible for clinical practice of all critical care nursing students of 3 training institutions.
I think that is enough. Thank you.
Go ahead,
Bro.
sister. Thank you.
Thank you, bro. I'm so happy to be invited to talk today because at an event like this, it's very seldom that they include nursing. And we are, as nurses, are very fortunate because we just follow the prescription of the doctor. I didn't prepare PowerPoint as I'm going to talk about experience, really experience-based. As a nurse, we have different roles. If I go to the first role, it's patient care. That is where we need to take the prescription chart, read it, understand it, and mix the medication. Now what happens is, unfortunately, being from a public hospital, our pharmacist doesn't work 24-hour. They are not on duty for 24 hours. So 4 o'clock in the afternoon, they go home, and then the microbiologist will call the ward or especially the ICU to say this and this has been cultured. And now the antibiotic is not in the ward because it's one, let's say it's a carbapenem, must come out of the pharmacy. Now we have this emergency trolley there in casualty. So now they call the matron in the office to get the key to go and find imipenem. Let's say it's now Sunday afternoon. Already all the imipenems has been taken through over the weekend. There is nothing. So now there's no one that can be a thief as a nurse. A nurse is a good thief. So now you go and scavenge all the other patients in your ward. Are they getting that type of antibiotics? And you take that antibiotic and you mix it and you administer it to the patient. If you can't find it in your ward, you go throughout all the wards in the hospital and you try to find some imipenem for this patient, for the 10 o'clock, for the stat dose, for the 10 o'clock dose, and for the 6 o'clock in the morning dose, 3 doses. So now, and you know, in our hospital, they issue the medication for 24 hours. So if it's for Friday afternoon that you send in the prescription, that one patient will get it until Monday morning. But now we take 1 year, we take 1 year, we take 1 year. So already the patient is left for the Monday dosage in the morning. You can give 3 doses for the Sunday. Monday morning, the 3 patients where you took it away is not having medication for 6 o'clock in the morning. It's a big crime. We're not allowed to do it. But there's a standing order to say you cannot call the pharmacist after hours because they are getting paid for extra hours when they come out. And we don't have money. So when I go into a ward and I take a clinical handover round in the morning, we find that the night sister will now say, we didn't have the dose for 6 o'clock. It's now already past 7. Please find a dose somewhere to give this patient the 6 o'clock dose. The 6 o'clock dose. The pharmacy opens at 8 o'clock. Now the ward gets busy. Obviously, we forget, as we're also only human. 10 o'clock, the doctors does the rounds, and the patient didn't have 6 o'clock's dosage on 3 patients now. But luckily, the other patient that was having this infection got the 3 doses until that morning, Monday morning. That is the one challenge that we have. When pharmacists don't, I know they follow SOPs and things, where we don't have some spare antibiotics in the wards. I'm talking wards, I'm not talking ICUs and high care. To at least help that patient with that type of antibiotic. It can be an antibiotic like ampicillin, for instance.
Some of them are on ward stock, some of them are not on ward stock. So we have this trolley in emergency department. And the key, no one can take medication off, so only the one in the patient care office is having the key. Then I'm going to the managerial side of nursing. Now, I'm also relieving of the hours, public holidays, weekends, night shift in the patient care offices as the matron. So now they come and fetch the key from us. Now, let's say more than one patient needs that specific type of antibiotic. Now we are forced to get out the pharmacist. And this has actually happened to us on an ICU patient. The patient, now we know that according to the sepsis survival bundle, an ICU patient should get the antibiotic within 1 hour after the doctor prescribed it, according to the criteria for sepsis. A patient in emergency department should get it within 3 hours, and also in the ward within 3 hours. So what happened was they called early morning around. I do not understand how doctors can find and decide to prescribe medication after hours, knowing the pharmacy is closed, knowing it's a big challenge for us to get the pharmacist out. So it happened, I was relieving on night shift, and they decided at around 10 o'clock the night they need antibiotics for this patient inside the ICU. Call the pharmacist, the trolley is empty. So she said, let's see if you can find this antibiotic in the meantime. Call her back, no, we can't find the antibiotic. Okay, she can come out, but we need to arrange transport for her because she stays very far and distant, and her car is broken, she can't come in. Now, it's quite difficult to find the driver at transport at 10 o'clock the night. I'm not sure what was on his agenda, but that phone was ringing and ringing and ringing. In such a way that I asked the porter to go to the transport, which is a separate building, to see where the driver is, because there's one driver on night shift. Only to find out that the driver went for CSSD somewhere to another hospital to get something for theatre the next day on the Monday. Eventually, when he came back, more than 2 hours has gone already. Now I called the pharmacist, got the address where the driver must pick her up. That pharmacist arrived in our hospital 5 hours after the doctor gave the prescription to the sister in ICU to give this medication, where it should have been 1 hour. So already we didn't follow the sepsis survival bundle accordingly, which is it's logistical challenges as a nurse that we have. The previous speaker talked about the paper gap, papers that disappear. You know, if you put the emergency department registrar in an ICU and you put the general surgeon registrar in an ICU, they know. But if the ones you put the ENT and the anesthesiast registrar in an ICU, now it's the nurse that must guide accordingly. So, and you know, nurses, we try to avoid paper. We're not good writers. So what happened also now, the nurse, I'm an ICU trained sister and I work overtime in the ICU. What has happened now, this registrar wants to know. The consultant said we must now order colistin. I'm not working permanently in the ICU. What do I know about going online to fill in the papers and things? And I need to explain to this ENT about that. Luckily, other sisters knew about that. I think that patient got the antibiotics maybe a day later. Because as nurses, we are not trained about how to order colistin. Luckily, working as well in the patient care office, I knew about, we have a circular that came out in the government in 2017, where it actually explained how how do you go about to get colistin. And this morning I've spoken to a consultant, a pediatric consultant in our hospital, and she said initially they usually waited 4 days for the colistin. That is how long permission takes before granting the colistin. And she said yesterday she ordered it in the morning and she got it in the afternoon, which is, as we think on a very sick patient, a long time already. So, and the third role that I want to talk about is education. And I want to say I'm the educator. So to my embarrassment, I can say, since the pandemic, no education was given regarding antibiotic stewardship in our hospital. The last training was done before the pandemic, and it was run by the chairperson of our antibiotic stewardship committee, Prof. Stolz. So thereafter, everything just fell flat. Currently, we have an antibiotic stewardship committee, of which I'm a member from education, from training side. So I'm embarrassed to say no training is happening in our hospital. Hopefully, before I go on pension, I hope to correct that. I'm going on pension in August, but I decided I will correct that. And then I told the chairperson of this session, I'm actually known as the fake IPC sister in the hospital. Their offices are next to mine. And when one of them, we only have 2 for 700 patients, which is not according to the ratio that we should have around 8. So everything, all the overflow comes to me. Regarding training and everything. So everyone knows me as the fake IPC sister in the hospital. Thank you very much.
Thank you very much. I think the speakers can have a seat here, sister. You can have a seat here. So we have come to the end of our afternoon presentation. I think we'll begin the question and answer session. Is there any questions? Yes, there's one over there.
Maybe while we're waiting, I saw she was still coming at the end of her presentation to colistin use in Kalafong and the way we approach it. So I must commend the pharmacy in Kalafong. I mean, we've got a system from the Antimicrobial Stewardship Committee where we've got a WhatsApp group, some members being present here, that when they receive a prescription for colistin, they get the culture result with that goes to the pharmacy. Immediately as the pharmacy receives it, it goes onto a WhatsApp group, and there's permission from the members of the Antimicrobial Stewardship Committee. This may involve the physician going to the ICU and checking up whether this patient actually needs the colistin or not. And in cases where we disagree with a prescription, we would contact the prescribing doctor and discuss with him. And in this way, I think we've had very few problems in issuing it on time. And I think we've saved quite a few people from unnecessarily receiving colistin. So well done to the pharmacy.
I definitely want to agree that that's really the one thing that I can applaud Kalafong for. Okay. That's the one thing I can definitely applaud Kalafong for is, as Prof. Diana said, like, I think the maximum time it takes for our colistin to come through is maximum 2 hours, and then it gets delivered, which is insane. So yeah, that's one thing that's actually really going well in our hospital for us, because we all know, like, if a patient needs colistin, you know it's a quite serious disease and things are hanging by a thread. So, like I said, kudos to Kalafong in that sense.
Okay, over to you.
Thank you very much. I know that in the previous session it was about 8 questions per person, so I'll disappoint and just ask 2. So the first question regarding the ethics about this. I know that change management in any situation is typically difficult, and in a hospital where everything is push comes to shove, it's a rebellion. So I like the point that it's more advisory and not mandatory to that. But how can you realistically bridge this to make it a feasible thing within the hospital sector so that it's not a crisis afterwards? And then just a second...
Maybe I should answer first. I'm a pediatrician. I can remember one thing at a time. Okay, so we've had some things on anaesthetist and ENT surgeons and whatever. So if I don't forget your second question, I'll be representing the whole of the pediatric community. Yes, I mean, I said it should be advisory rather than mandatory, but not meaning that these are going to be loose guidelines. I mean, these should be enforceable guidelines, but like I discussed now, is that the individual physician should still have a right to disagree with an antimicrobial stewardship committee, to put the issue there and say, I disagree with you on this specific patient, and these are the reasons why I disagree. And then there should be a mechanism for the committee to say, yes, in your specific case, we will allow exception and do this. But I think we cannot have an antimicrobial stewardship committee with rules where, like with us, you cannot get the colistin until it's approved. You cannot change those rules. Otherwise, it just becomes a talk shop. I hope that answers your question.
Yeah, no, I fully agree. It's a very difficult tightrope to walk at all times. And maybe just on that point now with the possible appeal process, this links to the education comment that was made earlier. I know that just from an educationalist point of view, competency frameworks in general is very a gray area when it boils down to it. Is there any national drive for a competency framework? Because, I mean, a day one doctor, pharmacist, and so forth should have representative AMS training so that this can be avoided. But it seems that this is more something that you get into where there's interest or where there's need and so forth. Thank you.
I think Natalie is actually the person who's mostly qualified because she serves on all these national advisory groups and what they involve. So maybe she's better qualified to answer that question.
Thank you. Yes, Prof. Kodir, there is a drive through the various councils. Like the South African Pharmacy Council has already changed and included it in its curriculum. We have worked with Honors de Poort and the HPCSA. So there is a drive and a specific section within the Ministerial Advisory Committee, as Prof. Kobane will also tell you. So I think that is a huge drive to have the education there. But I think it's also important, maybe from an ethical point of view, you can have the education, as Sister said, so you know now you know you have to give it within an hour. But if the logistical underpins doesn't enable you to do so, it's a challenge.
So, sorry, you said you had 2 questions?
That was
okay. I had 8. So, yeah.
I'll ask the rest of the questions.
Sure.
Okay. This is more of a comment maybe to sympathize with Sister Viet as well in her situation, and I think it opened up a door for an ethical dilemma here. When there are clear SOPs and guidelines set for nursing staff to start medication, that is a legal minefield that we open up for when a patient deteriorates and their legal representative starts to suing an institution. Now there is a question of there's not enough funds by the Department of Health to fund after hours for pharmacists, but on a distributive justice point, how fair is it to already pay out legal fees on already severely restrained system that barely have enough funds to treat patients properly? Now it needs to pay out millions in legal fees because we think we save on after-hour fees of a pharmacist. So it's just a comment of we are actually, where we are trying to save money in a system, actively violating ethics from a distributive justice point of view.
Chair, can I just maybe comment on that I think that is where we need the buy-in from management. And I think, Prof. Avenant opened his slide with management that we need their buy-in. But it's something that, from a pharmacist point of view, from the South African Pharmacy Council, that we've discussed many times. The pharmacy profession says that we are the custodians of medicines, but in many institutions only for 8 hours. So we've said this openly within our meeting. So we have challenged them to say that if you want as a profession to be the custodian of medicines, you should follow the medicine, doctors and veterinarians and nursing sisters that are the custodians of their patients for 24 hours. But then the pharmacy council, the pharmacists know that we want to be the custodians of medicines for 24 hours. But management, because they see the pharmacist still as a product, just as someone who's handing out the medicines. And that's why in one of my slides I said, unfortunately, the reason why many of these surveillance studies are done by pharmacists is to prove their worth, that they should be there for 24 hours, because you can't just be a custodian for 8 hours. Then you might as well just have a robot in there. Thanks.
Thanks, Prof. Is it online or is it you? Online. Okay, go ahead.
Okay, so we have an online question from Anonymous 27157. So whoever you are, Anonymous, thank you for that question. They're saying, what is being done practically with regards to antibiotic stewardship in University of Pretoria hospitals? When are the ward rounds? Who attends? Is it pharmacists or microbiologists? Is it students, nursing, management, IPC, and in which wards?
So regarding for Kalafong, which is one of the things I wanted to put on my slide, but we do not have clinical pharmacists. So there are no one doing any rounds. So basically our AMS is, we look at the scripts, we think, yes, no, definitely not, send this back. So that's a big gap that we have, especially in State Hospital, in Kalafong-wise now, because there's such a need, like there's a lot of patients and a lot of wards. And there's, as Prof can testify, that we are seeing a lot of patients lately. The influx of patients coming in lately is ridiculous. So there isn't time for every individual pharmacist to actively give time for their prescriptions and to go into the ward. So to be honest, it's just the physicians, they have to double check if there's everything there.
Yes, so that's not all of it. I mean, Kalafong does have an antimicrobial stewardship committee where there are representatives from each of the major groups of disciplines, meaning surgical disciplines, ICU disciplines, pediatrics. We've got a microbiologist, pathologist on the committee as well. Management is on the committee. Infection prevention controls on the committee. And the issues that we discuss, there are the things that would typically be discussed at antimicrobial stewardship ward rounds. So we do not have ward rounds as such at this stage. We are moving there. But I think the issues are discussed and the individual problems of patients, etc., are discussed on a regular basis. Thank you. Maybe somebody from Steve Beaker can say, but I mean, there's definite antimicrobial stewardship going on at Kalafong, although we do not have rounds per se. Thank you.
Prof, you seem to suggest that you have not only moved on from physical meeting, you are now online. Because that is happening online. The stewardship is happening. You are not physically there, but it's happening online.
Stewardship is physically in meetings and what's happening there, but also when there are immediate decisions. I get some very excited hands from the back. So yes, the meetings are real-time meetings now that most of COVID's gone, but also the decisions that we need to make on individual patients are made through a WhatsApp group and discussion on the WhatsApp group. So call that what you want, yes.
Currently at Steve Biko, we also have meetings online, but what I enjoy is all our head of departments sit into that meeting as they are a part of the committee. And I'm also responsible for the infection rate in our hospital, especially for catheter-related infections. So we have this base care project that we implemented. So in the antibiotic stewardship meeting, I know for the month of April, our CLABSI rate was 8%, of which it came down from 22% in January. So then they know where to focus on, especially in we have central lines. Not only the nurses must do their job, but the registrars, the doctors, the consultants, because of the high CLABSI rate that we had, they will now focus on, and they heard it in the antibiotic stewardship meeting, they will focus when they do their rounds to look at the central line function side. How does it look? How long was the line in? Is there temperature, patient spiking a temperature? So all the infection rates that I'm busy calculating, I receive all the data from the different, we only do it in ICU and high care, but we did it for 10 years in the wards, which was chaotic and underreported and overreported. I doubt all that numbers was correct, but ICU is quite clued up, the OPMs in the ICU, so they will send us, every week I get a list from each ICU of all blood cultures that was sent in, all urinary specimens that was sent in, tracheal aspirates, and then at the end of the month I will get a list to say how many patients did have central lines in, how many patients was intubated, how long, how many days were they intubated, how many days did they have the central line in, and then based on the data that I received weekly, I can confirm maybe with Prof. Baruch, I see this ICU had 3 central line infections, and then in my data that I receive weekly, I can pick it up as well as verification. That is why we can really say for sure what our CLABSI rate is in our ICUs, and we have 8 ICUs. We do it for pediatrics, we do it for neonatal ICU, as well as the high case in the hospital. And what is surprising, if we go to international data, is their urinary tract infections, catheter-related urinary tract infections is extremely high, which we don't find in our hospital. Our central line infections, the rate and the percentage is very high, and we know it should be less than 2%. And I mean, we sat with 22%, 18%, because we do it monthly, and suddenly it dropped down to 8%. Because of, we have 7 clinical facilitators, nursing facilitators in our hospital, of which is distributed throughout the ICUs, pediatric, ICU, neonatal. And we did the intensive education training drive in those places to teach again, update and teaching. And I believe that is why our infection rate, CLABSI infection rate came down, which now one or other doctor is now busy calculating the antibiotic use when we have a CLABSI, how much will it be for per 24 hours. So we discuss things like that on our antibiotics.
Thank you. I'm just scared that Anonymous, what was it, 175, is a pharmacist. Just to tell him that our chief pharmacist is intimately involved in the Antimicrobial Stewardship Committee, and she runs most of the issues there. So please don't shoot me.
Okay, question there.
So I just have a question on how do you think the communication, or what system do you think can be put in place to improve the communication between the different sections of the healthcare? Because we've got emergency medicine represented here, we've got pediatrics, pharmacists, and then nurses. How do you think that communication can be improved between those groups to improve the care and ensure that the patient receives the treatment quickly and effectively?
Today's a good start. I think, as I said on the slide of the managers, I think antimicrobial stewardship and hospital management should come much closer together. I think unless the managers in our hospitals see the importance of antimicrobial stewardship, you're going to fight the lost battle. So, and then I think the onus is on us as senior clinicians, senior pharmacists, etc., to make things work in the hospitals where we are. If we leave it to anybody else, it's not going to happen. So yes, there's a huge responsibility on us. I think we can do better.
Online moderator, nothing? Okay. Dr. Sherlock.
My question is to Dr. Mohale. I'm so glad we got a emergency care doctor, you know, to talk, because I think it's such a important area. So thank you, first of all, for your views, and I could associate with what you expressed. But how would you see, you know, antimicrobial stewardship being implemented in your setting? Like if you had the perfect world and you could get anything you want, you could even get Professor Said's, you know, BLCD that quick. How do you think we can start there? Because I think that's, you know, a place that we haven't investigated properly yet. Maybe just to say the last comment is because many times when I get family members or people saying they come from visiting someone in the casualty unit, you know, they'll be so distraught. And I'll ask why. And in this one instance, they said, because they went in there and they asked the nursing sister, you know, why didn't you wash my mother? And then the nursing sister said to her, is your mother alive? And she said, yes. She said they have so little human resources and so many patients coming in. So stewardship, do you think there's a place, even if you look at that in your setting? Thanks.
Thanks for the question, Prof. Yes, I believe there is a place. Starting here today with this training, with this workshop, I think if my colleagues basically working in the emergency department had this exposure that I had today as well, but obviously I'm here so I can go back to the department and share with them the things that were emphasized. Secondly, like I mentioned, multidisciplinary approach. So basically, we are not taking care of patients alone. It's in conjunction with the other specialities and the other team in the healthcare system. The issue, I think, also it's with recording. I've touched on that. Recording and file, our file system is we're still writing on the files, and then you find when the patient comes back, we have patients presenting multiple times, for example, in the emergency department with the same problem. They don't bring their copy of our notes, and then we basically back at square one because we don't know what has been done before. We can check on the system if then investigations has been sent to the lab. That also helps that at least NHLS, it's more of a universal thing. Patients coming from other hospitals as well, if there's investigations done via our NHLS laboratory, we are able to retrieve that. But I think there's an area of improvement in record keeping. If maybe we have a electronic system, it'll improve a lot in terms of the stewardship for antimicrobial use. And I've already touched on the turnover time for investigations. I feel like that also counts a lot, because if then we can have investigations as we order them, that directs our therapy in terms of the patient care. Also, vaccination helps. They've already touched on it. And infection control as well, bedside, like for the case you have given that the family member was not bathed, etc. But we all know that our healthcare system is overburdened. Like, I can give an example. In a normal shift that we have our P2 patients, our P3 patients, but also we are a priority 1 setting. So if then there's a patient waiting to be seen that is not a P1, I'm going to obviously give attention to the P1 patient that needs to be seen immediately. So it's also a matter of, like you've mentioned, human resource, but also that we don't have the appropriate resources, enough resources to care for our patients. There's also a shortage of beds in the hospital. So these patients that the family members are coming to see in the emergency department, they are technically not emergency department patients. They're ward patients that are waiting for a bed to open up in the ward. But then we are having the same number of nursing staff to look after it, to look after our own ED patients that are being offered emergency care, but also having to do ward routine for ward patients that are awaiting. So this is also a burden for our nursing staff in the unit.
Colleagues, any more questions? I like questions. This is the last one. She has one more.
I promise it's the last question. Okay. So yes, Dr. Mahali, I agree with you. I understand completely the resources. My question is now towards the chair and Prof. Vinny Naidu, while we have him here. What stewardship, as you've heard here, what would you say is your experiences within veterinary sciences in stewardship? And is there a way for us bridging the gap, doing rounds together, or so what is stewardship like in veterinary sciences?
I think I want Prof. Naidu to start that conversation, because we're having a similar conversation during tea time. Yeah.
I'm going to say non-existent. So the question was pharmacists being in rounds. There are almost no pharmacists working in the veterinary field at all. There's let alone a pharmacy school that trains towards anything in veterinary. So that's the first step. In terms of clinical pharmacology, I believe I'm the only clinical pharmacologist in the country. So that's an immediate no. Our specialist clinicians are doing the rounds, and that's it. There is no oversight, no discussions, and no sensitivity testing. I pulled our hospital records from 2020, I think. But 20% of all cases received some or other secondary laboratory test. Almost none of them were treated, at least none of them used those results to treat. All the animals were treated on presentation and discharge. So realistically, it is a lot needs to be done, and it is a resource constraint. So if you look at the constraints in the medical hospital, in the veterinary field, it's even worse. So in most of the state facilities, these are primary animal health facilities. Most of the vets have very basic drugs, and the state only gives them access to a few of the drugs, which penicillin and penicillin chloronic acid are the drugs they have. So that's all they can use, which is what they do. So the resources restrict you even further to what you can use. There's no choice.
Yes, so it's not all lost. Yes, we have a PhD program, one of my students, that is working on trying to come up with a multimodal model for antimicrobial stewardship. That will focus on preclinical training and then post-clinical training, because I think there's a big need. The other difficulty is that they're all species. So you have to consider rhinos, horses, they have a different protocol, different management in terms of disease. So for us, if we were to develop a guideline, for example, on antimicrobial stewardship, probably would be like a book. So it's something that, yes, we are working on to try to see how to best address it. So we are in a unique situation. Any other question before we close? No? Okay. Thank you very much. Thank you very much, colleagues. And I think I need to hand over to someone. I don't know who I'm handing over to. Oh, okay. Right. So I'll hand over to Natalie. Thank you very much for your attention. I think this is the end from me.
Yes, colleagues. So from my side and on behalf of the Department of Pharmacology, Faculty of Health Sciences, and then the School of Medicine at the University of Pretoria, I want to first of all thank each and every speaker that spoke here today. You know, when I first sent the email, I never received a no, just received an immediate, enthusiastic yes. And if you look at all of the speakers that spoke today, they are leaders in their field. They are extremely busy. So for them to take out one day to come and share, you know, what they know with us, I think for that, I am really, really grateful. So if you could just give them all a hand, please. Thank you. And then also the perspectives. Thank you for coming to share. Pharmacist and the nurse and the doctor, you know, for them as well, it was an immediate yes. And it was great to hear what's really happening on the ground, because I think it makes us think and it makes us be more aware in your specific role, you know, of how you can assist the person on the ground to really make a difference. Because at the end of the day, that's where we need to start making a difference to the patients. And then for each and every person that attended today, each delegate that was online or even in person here, thank you very much. It means a lot in terms of antimicrobial stewardship to see so many people interested, you know, from UP side to really make a difference in the various sites and the population that we serve. It shows your passion and your commitment towards the future of the patients and healthcare in general. So for you, I would also like to say thank you. And then just some administrative details is this will be a link. We will share the link with you so you can revisit some of the lectures. You can share it, you know, with your colleagues if you want, wherever you go. So the link will be shared with you. I think it will be, Louis, it will be on the Faculty of Health Sciences website and I think social pages where you can go and share it to create awareness of UP. And then we are looking forward. We wanted, in our first discussions, the faculty today wanted to start this as a launching pad, you know, to look at what is really happening at UP, and that's why we started with the current landscape. So we would like to invite you, if you want to partake in future initiatives in research focus areas, that is really where we are hoping to go as we get to know each other on this journey. So if you've got any ideas following today that you would like us to share, I would also then share it with my colleagues, and as we move forward, we are hoping this is the, you know, it might be the first, but there's going to be many, and we hope you will attend again. And then please just make sure that you sign the register when you leave, the CPD register, and then Keith is going to give a magic code to those that attended online, where they must just write their name and surname and then the code that Keith is going to send them so that they get their CPD certificates. And then outside is coffee and tea, and I hope cupcakes. My apologies for tea time. There was, you know, I'm sure you all went into the second session hungry, but that was not the intention. So at the next workshop, there will also be something there. So please take your cupcake and have a fantastic day. Thanks, everyone.